Good morning to all of the Pentecostal Assemblies of the World constituents. We are delighted and privileged to be able to come to you this morning and thank God for all of you that have chosen to tune in to this live stream. We're grateful and thankful to God for the privilege that we have to present today. I want to, first of all, um, share with you that I'm so grateful and thankful to our presider, the Honorable Bishop uh, uh, Theodore Brooks, and just grateful to God for the opportunity that He has designated us for this privilege to share with all of our constituents across the country the opportunity to present health and wellness information for our constituents that they might be blessed. So, Bishop Brooks, we thank you and we honor you for what you have provided us the opportunity to do. As well, we want to be able here this morning to present to you our team. Today, we will be talking about two really very important topics that affect and impact all of us in some way, some shape, or form. The first topic, which is really near and dear to my heart, that has to do with dementia and Alzheimer's. The topic that we will be talking about first is the aging brain, proven steps for identifying the signs of dementia and Alzheimer's disease. I have every confidence that you will be blessed by the information that's going to be shared from my team that's on board today to talk about this very important topic. The second that will follow us this afternoon with other members of our team will be the topic of ADHD. And so that will follow immediately behind us. So today, this early morning, Saturday, December 9th, yes, we're into the holiday season, and I trust that all of you will have a really blessed experience when it comes to Christmas in just a few weeks. But that said, I want to get right into the introductions. I have three members of my true team, and a special guest with us this afternoon. I'm going to allow my team members to introduce themselves. We have Dr. Mark Royster, we have Dr. Karen Douglas, and then we have Andrea Lynn. So I'm going to pitch it to them, let them introduce themselves, and then I'll come back and talk about our special guest, Dr. Karen Blair. Dr. Royster?
Thank you, Bishop Harrison, for the opportunity to share with our constituency of the Pentecostal Assemblies of the World and those who are joining in. They received the flyer or the text message inviting them to participate. I'm honored by our providing bishop as well, Bishop Theodore Brooks, for allowing us this opportunity. So I look forward to sharing some insightful information when it comes to research, diversity, and inclusion.
Thank you, Dr. Royster. Dr. Douglas?
Good morning, everyone. I'm Dr. Karen Douglas, and I again want to thank our presider, Bishop Brooks, for just giving us the opportunity to share and give you information that will help you to understand dementia and just be able to live a life of wholeness and wellness.
Thank you, Dr. Douglas. Andrea?
Good morning, everyone. And again, thank you, Bishop Brooks, for this opportunity. I'm delighted to be here and humbled for sure as a licensed clinical social worker, just to share with you my insight on caregiver support and how you can move forward in your journey with this disease process, and also give you resources as well. So I'm excited to be here. Thank you for the opportunity, Bishop Harrison.
Thank you, Andrea. And now, as it relates to our special guest, and by the way, I just assumed that everybody knew who I am. Dr. Roland Hairston. I'm a diocesan bishop at the Pentecostal Assemblies of the World, and I chair this committee on health education and wellness. So now that we got that out of the way, our guest this afternoon is none other than Dr. Karen Blair, DNP, Doctor of Nursing Practice. She is a board certified by the American Nurses Credentialing Center as a psychiatric mental health nurse practitioner. Dr. Blair is the former senior manager of research support at the John P. Hussman Institute for Human Genomics at the University of Miami's Miller School of Medicine. Her role at the University of Miami supported efforts to recruit, enroll, and retain African American and Hispanic participants for Alzheimer's disease research. Additionally, she oversaw efforts to collect biological samples and phenotypic data of the African American population for Alzheimer's studies. Dr. Blair is an experienced healthcare provider who has extended culturally sensitive professional nursing services in various clinical and research settings to patients across the lifespan. Finally, Dr. Blair is the founder and CEO of Caring for the Caregiver, a nonprofit organization that provides comprehensive dementia care to the Southeast Florida community. Throughout speaking engagements and local collaborations, she has been instrumental in bringing awareness to the plight of Alzheimer's disease to caregivers. That said, we're going to turn it over to her, but let me share with you our objectives in this presentation. There are 4 objectives that we are concerned with today. So in this discussion, the aging brain, proven steps to prevent dementia are as follows. Number 1, identifying risk factors that accelerate the aging process. Number 2, compare and contrast normal aging with pathological aging. Number 3, outline evidence-based lifestyle factors and non-drug interventions that slow the aging process and prevent dementia, along with participation in research for African Americans, why that is significant. And lastly, explore the emotional and psychological effects of individuals with Alzheimer's disease and their family members, and share anecdotal experiences of the caregiver and how to care for the caregiver. Brothers and sisters, ladies and gentlemen, this is indeed an exceedingly important topic for all of us, because I can't help but believe that in some way, all of us are affected by someone in our family that has been affected by dementia and or Alzheimer's disease. I think to some degree we have not been informed, and thus the need for this kind of presentation and information. So we pray you'll sit back and take it all in, and we pray again God will feed your spirit with this information so that we can all be better as a result of all that is shared today. So at that point, with that as mere prelude, Dr. Blair, we give it into your hand.
Thank you so much, Dr. Hairston. And thank you to the Pentecostal Assemblies of the World. Thank you for having me here to talk about this incredibly important topic. And we're, again, talking today about aging and the brain. Next slide, please. So what I will be talking about today, here are some of the points. I'm going to discuss aging and the aging process. I will describe attributes of normal aging, discuss abnormalities related to aging, compare and contrast normal aging of the brain with disease in the brain, and identify risk factors that accelerate the aging process. Mm-hmm. Lastly, I will outline evidence-based lifestyle factors and non-drug interventions that slow the aging process and prevent dementia. Next slide, please. So, what is aging? What is aging? Aging is a complex process, and we are all doing it. It alters the organs, the tissues, and the cells of our body, It's a universal experience. It's inevitable. We're all aging. It occurs at varied rates between people. Even in one body, aging takes place at different times. I'll explain that later. And can be described in chronological and biological terms. Next slide, please. So, biological age. Well, actually, I'm going to start off with chronological age, because when we talk about age, this is what most people refer to. What is chronological age? It reflects the time that's passed from birth to a given date. So from your birth to today, for example, I might say that if it was true, 25. Chronological age, the number of years that you've been here. Now, when we talk about biological age, we're talking about one's well-being, functional capacity, and mortality risks. So we could be talking about the age of your liver. We could be talking about the age of your kidneys. And today, we're going to be talking about the brain.
Good.
Next slide, please. So let's review normal aging. All our cells change as we age. They're changing right now as we are all sitting here. It's a constant process. These changes include abnormal cell function and loss of cell function. That is normal aging. As we age, more lipids, more fats are found in the cells, and waste products accumulate in the tissues. That is normal aging. Vital organs and tissues lose some function and become stiff. In addition, blood vessels become stiff. Organs lose mass. And in the case of the brain shrinks. Next slide, please. So to understand the aging process, we must look at factors that affect lifespan by contributing to normal and abnormal aging. Next slide. So there are factors that influence lifespan and potentially accelerate aging. For example, exercise can influence lifespan if you do it. Nutrition can affect lifespan. If you eat poor, if you have a poor diet, it's going to affect the lifespan negatively. If you have a healthy diet, it will affect the lifespan positively. Substance use. Most substances you have to be, they don't help the body. There are some substances, if used in moderation, can be helpful, i.e. red wine. Next slide, please. So again, factors that affect lifespan and actually accelerate the aging process. That would be tissue damage, natural selection, unhealthy lifestyles, oxidative damage to your cells, a drop in the number of cells, a decline or loss of cellular function, and DNA modification. Next slide, please. So, what I want you to take away from this today and really focus on is that the basic building block of tissue, organs, liver, kidney, all of those tissues are cells. That's the basic building block. The human body is made up of trillions of cells. So as you and I, we are here, we are units that include trillions of cells. There are 8 chief cellular functions. One of those cellular functions is carried out via nerve cells. So they're muscle cells, There are cells for the skin. Today, I'm talking specifically about nerve cells, otherwise referred to as neurons. Next slide, please.
Mm-hmm.
So let's talk more about these neurons. Neurons, by way of chemical and electrical impulses, send and receive information throughout the spinal cord and the brain. I'm going to say that again because I want you to visualize this. You have a brain, and that connected to the brain is the spinal cord. And in that system, by way of chemical and electrical signals, nerve cells send information. They send messages throughout the body that enable an individual to perform tasks like eating, walking, talking, and yes, thinking, all done in the brain and the spinal cord. Next slide, please. So let's zoom in and let's look at what a normal neuron looks like. So what you see in this frame, in the middle, you're looking at a normal neuron. There are two ends of this nerve cell, this neuron. In your upper left corner, you see some branch-like structures. Those are referred to as dendrites. And at the end of that tail-like structure, that axon, you see what is referred to as synaptic and or synaptic terminals. So again, there are two ends of this cell. The branch-like structures, the dendrites, the axon, that's the tail-like structure, and then at the end, the finger-like structures, which are synaptic terminals. The other thing I want you to notice here is that in that upper left-hand corner, you see another tail up there. I want you to notice that that tail at the end, those are terminals communicating with the branches of this cell in the middle. And then if you look at the bottom portion of your screen, you see those terminals again, synaptic terminals, and some branches at the end because that cell is trying to communicate with the other cell. What I need you to take away from looking at this is that you've got those dendrites on one end, you've got the finger-like structures at the end, the terminals. In the middle, you have that axon. Between the cells is a gap. There's a gap between those cells, and it's incredibly important that the cell is functioning properly so that the messages that are being sent through that cell can reach all the other cells. So keep that in mind. Next slide, please. Here's just another image of that same normal cell. Take note of the branch-like structures on one end, the dendrites. You see the axon, which is that tail-like structure. And again, at the end, you see finger-like structures, which are the synaptic terminals. And you see what a normal neuron might look like under a microscope. Next slide, please. Okay, so when we talk about normal versus disease aging in the brain, here's what we see. From a clinical perspective, in normal aging, you might see mild defects in short-term memory. That's normal. From a molecular standpoint, you might see mild accumulation of some substances. I'm going to go into that a little bit deeper. Those substances are what we refer to as amyloid plaques. Again, in normal aging, you will see that. Normal aging also includes impaired synaptic function. Remember I mentioned to you that there's a gap between the cells? I want you to keep in mind that gap between the cells, very important. Each end of the cell, the synaptic functioning of the cell, very important. But as we get older, it is normal to have impairment. Those cells don't function as well as they used to when you were younger. As we age, it's normal to have impaired synaptic function. Now, let's go back. Let's talk about pathology in aging. From a clinical perspective, there's severe defect in short-term and long-term memory. That's not normal. From a molecular standpoint, there's severe and diffuse accumulation of those plaques that you would see in a normal aging process. In an abnormal aging process, you see an accumulation of those plaques. Lastly, there is neuronal loss and synaptic loss of dendrites, those branch-like structures that I showed you, when you have pathological aging in the brain. Next slide, please. So, what you're seeing here in the middle of your screen is a drawing of the brain. On your upper left corner, you're seeing what I just described to you before, which is a normal neuron. And remember, in that normal neuron, impulses, electrical activity, chemical activity is taking place in that neuron to help you do things like walk, talk, and think. Also, I want you to make note here, on the left side, that brain that you're looking at, the volume, the structure of that brain is intact. It's fine. It's normal size, normal shape, etc. Now, when you look to the right side of the drawing, you see something a little bit different. You see that nerve cell with some particles on the outside of the nerve cell that can become very problematic. And those problematic nerve cells now cause the brain, as you see on the right-hand side, to shrink and lose volume. And so I want you to know here that if that nerve cell is now being damaged by those bodies, those particles on the outside of that nerve cell, how is that going to affect your ability to walk, talk, think? You think that's going to hamper your ability to do those things? We'll come back to that. Next slide, please. So remember I showed you the normal neuron. This is what an abnormal neuron looks like. Now, you may have heard about amyloid and tau proteins that build up in the brain and cause problems. This is true. But what I want you to know is that we all have amyloid and tau in our brains. This is normal. It is necessary. We need those molecules for cholesterol and for the processing in the brain. We need that. It's when there is an overabundance of these molecules that you see problems. And here, take a look. Remember those branch-like structures? There you see them there. Those are the dendrites. But if you look just below that, you see some stringy-looking items there. That's what we call tau tangles. You're having problems now inside of that cell body. You're having obstructions that shouldn't be there. And if you have obstructions, you're going to have problems with the signal in that cell.
Right.
So that's number one. Inside of that cell, you see what we call tau tangles. Now, I want you to think about outside of the cell. What happens? Outside of the cell, we see a buildup of amyloid proteins. And when those proteins start building on each other, they form what we call plaques. And in this case, we see a buildup of amyloid plaque at the ends of those dendrites, at the ends of those terminals. So now, if you have those amyloid plaques blocking the messaging between those cells, what do you think is going to happen to the messaging
Right.
to the rest of your body? Right? Your brain is trying to tell your hand or your legs to walk. Do you think there's going to be a problem getting that message through those plaques? Absolutely. Next slide, please.
Good.
So here you have, again, what it might look like under a microscope. You have those healthy cells. Look at those healthy cells. You don't see an accumulation of those amyloid plaques outside of the cell. But if you look at the Alzheimer's cell, we'll go deeper into this, you see those plaques on the outside of the cell, which is interfering with the messaging between those neurons. Next slide, please. Okay. Again, just to clarify, in the upper left corner, you see a neuron. And you see that the messaging in the neuron goes from the dendrite down to the finger-like structures, the synaptic terminal. And you see that synapse, that gap, that's so important. You don't want anything building up between that gap because you're going to have a problem with that electrical information getting through to the next cell. Dysfunctional neurons can lead to various adversities that include what we call neurodegeneration. And in neurodegeneration, you have a slowing, progressive loss of nerve cells in specific areas in the brain, such as a part of the brain called the hippocampus, where memories are stored. You can also have cell death. So think about this. There's a part of your brain, it's called the hippocampus. And in that hippocampus, many of these cells are stored. We know that the hippocampus is where memories are stored. So imagine if you have a place where your memories are stored, and now you have dysfunctional neurons there, you're going to have interference with your what? Your memory.
Good.
Next slide, please. So there are several factors, including gene expression, that may contribute to cell dysfunction. So infections can cause problems for you, inflammatory responses, metabolic issues, diabetes, cancers can cause problems. Also, age-related issues, neurodegenerative issues, such as Alzheimer's. Next slide, please. So, I want to talk here about genes. The basic functional and physical component of inheritance are your genes.
Good.
Now, I need you to know that that cell body, that neuron that I showed you before, you might have noticed there was a nucleus in that cell body.
Right.
That nucleus, you'll find DNA there. And that's where your genes are stored. So imagine if you have a dysfunctional neuron, you can have problems with genes. Anything that goes on in that nerve cell, if it's not functioning right, can show up in different ways. I'll go on and clarify that. Genes are made up of a sequence of DNA. Again, that's found in the cell. Human beings have approximately 20,000 to 25,000 genes. Genes store information needed by organisms to manufacture specific proteins and dictate human growth and development. Genes are stored in the nucleus of the cell. So again, I want you to go back to that neuron, that normal neuron that I showed you in the beginning. In the middle of that neuron was a nucleus, and that's where genetic information is stored. Next slide, please.
Mm-hmm.
So how does gene expression contribute to cell dysfunction in Alzheimer's disease? So what I want you to know here is that a hallmark sign of Alzheimer's disease is a buildup of those amyloid plaques outside of the cell and those tau tangles inside of the cell. Remember that visual that I gave you? So there is a gene. That gene is referred to as APOE4. APOE standing for apolipoprotein 4. And that gene increases the risk of AD and is associated with the worst form of Alzheimer's disease, AD. APOE4 leads to inefficient transporting of cholesterol and different types of fat through the bloodstream. If you have the APOE4 gene, it predisposes the individual to inefficient transportation of cholesterol and different types of fat through the bloodstream. So what do I want you to take away here? Take away from this part. I want you to know that amyloid protein, tau protein, these are proteins that you find in the brain. Proteins, they're lipid proteins, they're fats. So now, if you're already having a problem with these proteins moving properly through the brain, and then you have a gene that makes it even worse, how do you think that's going to affect the communication between the cells?
Mm-hmm.
It's going to make it even worse, right?
Yep.
If you have this gene.
Yep.
Next slide, please. So there are actually 3 variants, we refer to them in science as 3 alleles of the APOE gene. The first variant, the first allele is APOE2. Individuals who have APOE2 actually have a protective factor against developing AD. Individuals who have APOE3, that's 75% of the individuals who carry this gene. It doesn't hurt, it doesn't help you, it's neutral. But those individuals who are carriers of APOE4, meaning that they got a copy from either their mom or they got 2 copies, one from mom and dad, those individuals are at risk. I didn't say they will develop, but they are at higher risk of developing Alzheimer's disease. Next slide, please. So let's drop back for a second, because we looked at this issue on a cellular level. I'm a big believer of understanding what's happening at the cellular level, because after all, we are trillions of cells walking, talking, doing whatever. So if you take care of your cells, you're taking care of your entire body. Moving on. Is Alzheimer's the same as dementia? I want to clarify that terminology. And I want you to think about dementia as an umbrella term. When we talk about dementia, there are many different types of dementia. You might have heard of vascular dementia, Lewy body dementia, frontal temporal dementia. Today, I'm talking about the most common form of dementia, and that is Alzheimer's disease. You'll hear me refer to it as Alzheimer's dementia. It accounts for 60 to 70% of all dementia cases. Next slide, please. So, Alzheimer's disease is an irreversible, progressive brain disease that slowly destroys the brain cells that control memory,
Wow.
thinking, language, and judgment. Over 6.7 million individuals live in the United States with AD. There are two types of AD. There's early onset, and then there's late onset.
Mm-hmm.
Early onset, you'll see that age 60 years and younger. And usually that indicates too that you're dealing with a different type of dementia. But if you do see Alzheimer's in an early, at an early stage, it's 60 years of age and younger. Most cases, Alzheimer's dementia, we see it at individuals 65 years and older. Next slide, please. Oh, before you go on, can you back up one? Thank you. I want you to take note here. Look at that normal brain, normal anatomy, normal volume, and look at that Alzheimer's brain to the right. It's smaller, less volume. Next slide, please. So oftentimes people say to me, oh my gosh, I'm losing my memory. Do I have a problem? Or my mom, I think something's wrong with her. So let's talk about this scenario. I love this scenario. And that scenario is, where are my car keys? And I know many of us can relate to that. You're maybe getting ready for an event. You're looking for those car keys and you can't find them. And you think to yourself, oh my gosh, the same thing happened yesterday. Do I have a problem? Next slide, please. So I want to talk to you. I'm going to give you an example about how this affects people, the stages of Alzheimer's dementia. This is Mr. Davis. During early dementia, Mr. Davis may misplace his car keys. They've been in the same place all the time, but eventually he finds the car keys. That's early dementia. In middle, moderate dementia, Mr. Davis may notice that he cannot find his car keys. He's looking all over for the car keys, but eventually Mr. Davis forgets that he was looking for the car keys. That's your middle, moderate stage. Your late, severe stage dementia is when Mr. Davis sees a set of keys and no longer understands what those keys represent. That's your late stage dementia. Oftentimes what you're going to see here are individuals who need total help with activities of daily living, dressing themselves, toileting, certainly not driving in late stage dementia. Each stage typically lasts about 2 years. Next slide, please. So how do I know if I have dementia? I'll go through these quickly. 10 warning signs: memory loss that disrupts daily living, difficulty completing familial tasks, trouble understanding visual images and spatial relations, misplacing things, decreased or poor judgment, withdrawal from work or social activities, changes in mood and personality. I didn't go through all of them, but what I do want you to notice about the ones that I did, especially at the end, don't those symptoms mimic other symptoms? Case in point.
Yep.
Withdrawal from work and social activities, changes in mood and personality. Some of these symptoms look like depression.
Mm-hmm.
So don't always assume that if you see these signs of AD, that they are AD. No. You need to talk with your primary care physician, nurse practitioner, or healthcare provider about what you're seeing, and then expect, if you really are having AD-like symptoms, to get a final diagnosis from a neurologist. Next slide, please. So let's talk about non-pharmacologic interventions, interventions without using medications to address some of these issues. Next slide, please. So there are, in fact, lifestyle factors that can help to prevent or delay the onset of AD. I want you to keep in mind, there is no cure for AD right now. But what you can do to support brain health is engage in healthy lifestyle behaviors, such as being socially engaged, avoiding isolation, talking with people, address hearing loss. If you're suffering with hearing loss and the doctor says that you need hearing aids, it's better to wear those hearing aids than to tax your brain with trying to hear when it could be using those cells for other functions. So take care of your hearing.
Good.
Engage in cognitive activities.
Mm-hmm.
Yes, playing games, brain games, that's very good. It's stimulating for the brain, helps to develop new brain cells. Consume a portion controlled diet. There's some evidence that following a Mediterranean diet, I'm not recommending any specific diet. I want you to know here that a diet that's usually low in fats, doesn't include fried foods, that's not helpful. Increasing your green leafy vegetables, your fruits, these are good things. They include chemicals that we refer to as antioxidants. That's a whole other conversation, but these chemicals are very helpful to keeping your cells healthy. And limit your alcohol consumption. Next slide, please. So these lifestyle factors also include controlling what we refer to as comorbidities. So a comorbidity might be hypertension, high blood pressure, diabetes, high cholesterol. Controlling these issues is very important. Why? If you have high cholesterol, your body's producing too much of these fats, well, that's going to be putting more stress on those cells to keep those fats moving properly, right? So you want to control your cholesterol, control your blood pressure so that your blood vessels and your heart can keep circulation going, keep those cells, new cells producing. Don't smoke. That's not healthy at all. Next slide. Let's talk about this. This is exciting to me because years ago I read a book by Dr. Bruce Lipton, and the book was called The Biology of Belief. And Dr. Lipton really gave us some insight many years ago about the outside factors that can adversely affect our cells. Social determinants of health can profoundly affect a person's health, including their risk for dementia. So, social determinants of health are conditions in which people are born, they grow, they live, they work, they age. Some examples of social determinants of health are your education, your income, your employment, your housing, your food security, transportation, access to healthcare, social support, discrimination, violence. All of these factors can affect you on a cellular level. For example, if you are experiencing problems with income, doesn't that affect your stress level? Now you're worried about paying the bills. You're worried about how am I going to buy my medication? You're worried about. That's going to affect your health. That is going to express certain chemicals in your body, and it's going to go through those nerve cells, and it could actually lead to adversity in those nerve cells functioning properly. Next slide, please. So I love this. And most of us can relate to this. Music should be observed as a non-pharmacological, non-invasive drug therapy. How many of us listen to our favorite song and you get that instant smile on your face and you feel good? Well, when you feel good and you get that smile on your face, or you're actually even moving to the music that you love, there are chemicals being released between those cells that are helpful to circulation, helpful to minimizing the effects of elevated cholesterol, etc. Next slide, please. Again, to support normal aging, research indicates that there are neural, cognitive, and emotional benefits to engaging in musical activities. Music therapy that includes AD patients and their caregivers benefits both. Music is effective for the rehabilitation of age-related neurological diseases. So it's helpful for that AD patient, building those connections. Next slide, please. These are just some resources. Do you mind going back just one slide? Okay, so what I want to make sure we add in here too is that the musical activity is very helpful in stimulating the brain and helping to make sure those connections throughout the cells are maintained and enhanced. If you add movement to it as well, exercise, it's very helpful. Exercise, when you're exercising, there are chemicals that are released in those nerve cells. Case in point, there are chemicals such as dopamine, serotonin, chemicals that are in the cell that give you that feel good, that help you also with exercise. Exercise helps with your cardiovascular system, which will help with the volume, your brain structure. Exercise actually increases volume of your brain. It changes the structure of your brain. So remember earlier in my conversation, I spoke about a place in the brain, the hippocampus, where memory is stored. Guess what? Do you know by exercising, by dancing while you're hearing that feel-good music, that you're actually increasing the volume, creating new nerve cells in that hippocampus? And that research indicates that exercise is helpful to keeping your hippocampus healthy. Yes. So exercise, listening to music, reading, things that are going to stimulate your brain are going to be helpful to delaying any onset of Alzheimer's disease. Also, understanding the genetic component of Alzheimer's disease and doing our best to delay the expression of those genes is helpful to taking good care of ourselves and avoiding the ravages of Alzheimer's disease. Next slide, please. So these are just a few resources. The Alzheimer's Association has some wonderful resources. You can reach out to them at alz.org. They've got a lot of information about this disease, educating yourself about the disease. Sometimes just knowing is very helpful so that it eliminates fear and eliminates uncertainty about symptoms that people might be seeing in their loved ones. You have the National Institute for Aging and some others there. Take a snapshot of that. Reach out to them for more information. Next slide. And on that note, I will end, and I will again thank you for your attention to this information.
Thank you, Dr. Blair. Excellent presentation. And up next is Dr. Royster.
All right. Thank you so very much, Dr. Blair, for a robust and just a thorough presentation. We are full. You shared so much, and it is palatable. It is easy to understand. And thank you for your commitment in sharing. And I know you have a strong passion for this topic. Thank you so very much. It's amazing that I was thinking back, reflecting on what you were saying about music earlier in my ministry. I had a nursing home ministry, and there was a gentleman who was once a pastor. He was up in age, and he was suffering from Alzheimer's. And they would wheel him in along with the other folks, and they'll go into this room. And, I would teach and preach and all of that. Didn't get much of a response, with that. No matter how much I tried to hoop and holler, that was okay. But when we played music, this one elder pastor, he was up in age at that time, suffering from Alzheimer's. When we started singing the songs of Zion and started worshiping and singing, he would jump up from his chair, his wheelchair, and just slowly move around the room, raising his hands as if he was worshiping. And there was something about the hippocampus, that memory of worshiping, the memory of those songs did something to him. And I'm sure you and others can speak to that. But it was amazing. And that brought back some memories, a flood of memories of how that individual remembered the music, the songs, and the times of worship. But what I'm going to talk about today is we're going to talk about research. And I just hope to keep you just a few moments there, talking about diversity, equity, and inclusion in research. And we have an issue. When it comes to research, especially when it comes to Blacks or African Americans or those who are people of color. It is not that there's a barrier to research. It's not that the researchers do not want people of color. It's just that people of color have issues, and that issue is not, I won't say it's not unfounded. There's a reason why, and we're going to cover those. So let's go to the next slide. Let me just get straight to it. So one of the reasons why a lot of Blacks specifically, but other groups do not participate is because of trust issues. And the lack of help-seeking behavior is often a result of mistrust. And so one of the first things that when it comes to research, we try to recruit people to participate in research, give samples, participate in Alzheimer's or whatever it might be. And one of the first things that come to mind is the Tuskegee syphilis study, which was conducted between 1932 and 1972. And we all know the story about nearly 400 Black sharecroppers with latent syphilis misled and denied treatment by the U.S. Public Health Services in exchange for enticements such as burial insurance. And so we hear about that, and people say, no, there's no way they're going to use me as a guinea pig. They're not going to use me because I remember what happened with the Tuskegee syphilis study or the research done there. And then most of us, not many people, know about the Henrietta Lacks story. When this woman, a young woman, and I just read it, Henrietta Lacks, she was a Black young woman and a young mother, and she died of cervical cancer in October 1951, just 8 months after her cancer diagnosis. Legacy lives on through an immortal line of cells known as the HeLa cells. It's amazing that these cells continued on. And the bottom line here is that they used those cells to further their research. Now, the thing is, those cells benefited a lot of people globally. But the thing about it is her family did not know, nor did she know what was going on. And so there are trust issues. People
Right.
just don't want to participate because they just don't trust the system. But I would be remiss if I did not let you know that Blacks were not the only ones who were mistreated or who were not taken seriously. So let's go to the next slide. So there were other unsavory reasons and things that happened when it came to research. And pardon, the slide is kind of off-centered. But there was the uranium experience in 1946, 1947. There was the plutonium experience around the same time. There was a project called Project Chatter to get people to tell the truth. It was a truth serum. And they were using people without their knowledge, without their approval. But it goes even further than that. The Nazi concentration camps was full of research. People were given vaccinations or radiation treatments unbeknownst to them or without their consent. And that's the key word, consent, without their consent. Now, of course, we know that in 1940s, that led to the Nuremberg Code. It was a war crime. But then there are other research that was done nefariously. Holmesburg Prison in Philadelphia, dermatological experiments with commercial cosmetics and toiletries and hair transplants and all these other different things going on, the yanking out of fingernails, the exposure of multiple radioisotopes and LSD, all this research. But this was prior to many of the laws that we have in place now. One other thing that I should mention is that soldiers exposed to foods of cobalt, radiation, fed to soldiers. All of these things, you say, how in the world could they do that? How could they get away with it? Well, back then, they did get away with it. But now, all of that is pretty much brought under controls of laws, international laws. So let's go to the next slide. And now we have issuing trusts. While there were trust issues, world organizations, especially our government, came up with these ideas and these laws to prohibit such activity from taking place. And the main thing we're talking about now is having consent. So on the left side of the screen, we have professional codes of ethics, professional groups such as genetic counselors and teachers and nurses. There's collaboration between professional groups working in research. There's societal codes of ethics, human rights organizations now, international courts, governmental oversights, federal as well as state. And so one that I'll read is in the middle here. We talk about the IRB, the Institutional Review Board, is the institutional entity charged with providing ethical and regulatory oversight of research involving human subjects. This was established in 1974. So what I'm showing you is that there are governing bodies now that ensure that people who are participating in human research, that they give their consent. They know exactly what is going on. And for the most part, if they no longer want to participate in a research study, they can stop at any time. They can say, I feel uncomfortable. I no longer want to participate. So there are things in place now. We have the International Compilation of Human Research Standards is a listing of over 1,000 standards on human research or human subjects protections in 131 countries. Standards may include laws and regulations and guidelines. So this is not just something for one of the states in the United States or the United States as a whole, but we're talking about governing bodies around the world. And those research studies, they are controlled. There are things that the principal investigators must do to ensure that those things don't happen. So it doesn't happen. Okay. So let's go to the next slide here. So there are participation issues, as I mentioned before. Okay. So Black Americans are most likely to develop AD and dementia, as Dr. Blair pointed out, compared to non-Hispanic whites populations. But we asked the question, why is this? Why do they get dementia? And not just that, but why is there a lack of participation in it? Well, to answer the first question, greater familial risk of AD, limited healthcare access, that's a problem. There is a disparity when it comes to healthcare. AD patients identified at later stages, later stages because of whatever reason, they don't participate, they don't eat healthy, there's a lack of access to healthcare, so forth and so on, just a vast amount of reasons why. And the poorer treatment outcomes. But on the right side is what I want to particularly pay attention to, is that Black Americans make up only 3 to 5% of those who participate in clinical research and clinical trials. So what are the unintended implications? What are the unintended consequences? Well, the fact is, research benefits those who participate and who participate in the studies. Okay, I apologize for the overlap in reading there. And despite significant medical advancements that have yielded improvements in health and longevity of older American adults, older Black Americans remain relatively disadvantaged in overall health status compared to the overall population. One of the reasons why, as I said before, is there's a lack of participation. So many of the drugs and many of the things that are offered to those who participate. Their samples are being taken. Their samples are used. And although we are 99.9% the same genetically, there are some differences. So it is important for us to consider participating in the research. And if we do not participate, then we will probably get the same kinds of results. So let's go to the next slide here, please. Okay, so there are opportunities to participate. And while I know of several organizations that offer research, I know the University of Miami is engaged in studies and other places as well. I would be glad to share more information of how our constituents can participate in research. And just to be honest and transparent, while it may not necessarily affect you at the moment, we have to look toward the future. We have to look toward the generations that are coming down the pike, because research is very, very important to determine what is causing this disproportionate of diseases in the Black community versus the other populations. So with that, I am done. I just want to mention that participation is a very key component to getting positive results. If we do not participate, then it makes it that much more difficult to understand what is affecting our communities and what is affecting our population. Thank you, Bishop. I am done.
Thank you, Dr. Royster. Indeed, it is imperative that we be more participatory in the research, particularly around dementia and Alzheimer's, because it is so critical that we are a part of the remedy. And the only way we can be part of the solution is to be part of the research as well. Dr. Douglas, your turn.
Yes, Dr. Blair gave us a wealth of information on dementia and the various types of dementia. And thank you, Dr. Royster, for expressing the importance for the needs of Black and Brown people to participate in research. And as I was looking up some of the information, I found that among Black Americans age 70 and older, 21%, a little bit over 21%, are living with Alzheimer's disease. And African American and Hispanics are at the highest risk of developing the disorder. And I'm going to talk a little bit about the psychological impact of this disease on not only the individual, but the caregivers as well. And when in doing so, I thought about the scripture, John 10:10, that says, the thief comes to steal, kill, and destroy. And when you look at this disease, the issue is that the thief steals the memory, thought processes, and ability to comprehend. He kills the core essence of the person, and he destroys the hope and causes despair and devastation. Currently, worldwide, more than 55 million people have dementia, and over 60% of those live in low and middle income countries. And every year, nearly 10 million new cases are discovered or diagnosed.
Wow.
And, you know, we talk about normal aging versus dementia, but many times people that are actually struggling with dementia, they're the ones that notice the decline first. Research has shown that if you kind of think you're having some form of memory decline, you probably are. But as Dr. Blair said, it doesn't necessarily mean that it's due to dementia. It may be due to some other psychological and or medical conditions. But those early signs are picked up by the individual. And can you even imagine how it would affect the individual if they know that something is wrong, but they're not able to actually talk about it or put their finger on it? You know, they know that it's not just I'm misplacing my keys, but they're becoming more confused in their thought processes. They're struggling with being able to comprehend conversations. Can you imagine just how devastating that may be? And when they, you know, and the family members, they may notice a decline, but I don't think that they really many times understand what it could be doing emotionally and psychologically to the patient or the person that is actually experiencing it. And the symptoms and the emotional responses to the disease can vary from person to person. And that could depend on the area in which the brain that is affected and the extent of the damage. So psychologically and emotionally, there is that forgetfulness. They may have difficulty with reasoning or problem solving, paying attention or concentrating. There may be a decline in their thinking speed and ability to communicate effectively. Difficulty following directions and reasoning, and their organization and planning may be disrupted, and just being able to understand and complete difficult tasks. And as Dr. Blair said, there may be some difficulty with their spatial skills. They may become confused when driving. They may get lost easily. They may wander around. I know I had a situation with my aunt that recently passed. So my mother has three sisters that struggle with dementia. One had Lewy bodies dementia, and then the other two had Alzheimer's. Both the one with Lewy bodies and more recently, one of my aunts with Alzheimer's disease, she passed away. And the other one that remains, she is pretty much in a state where she doesn't even know or can perceive of who she is. She thinks that her son is her boyfriend. And if you engage with my cousin on any level, she becomes aggressive and very jealous. And so as the individuals vary in the way that they actually experience psychologically the disorder, they may have, some people may, when they first get the diagnosis, they may be in disbelief, they may feel devastated, they may be angry, but others have a sense of relief because now they understand, they've been able to give a name to what they're experiencing. They begin to be able to have the opportunity to plan ahead, to say, these are my wishes. The family members are able to get treatment plans put in place to be able to not only understand and cope with what is going to happen, but what should they expect? Can you imagine someone that you love, that you've seen in a place where they were strong, they were educated, they were able to take control, they were leaders, and now you're seeing just a shell of a person. My cousin, whose mother just recently died, she described the disease as being disrespectful. She said that that the disease comes in and it actually kills your loved one before their actual physical death.
Right.
She expressed feelings of anger, grief, fear. It was expressed that, being incompetent, not knowing what to do for her mother, not knowing if her mother really understands. I know just before my aunt died, I had an opportunity to visit with her, and her body was good. She was able to get around and move around just fine, but she asked, probably within a matter of, I'll say 5 minutes, she asked about my mother, who had passed away a couple of years ago. So what I told her is, I said, she's doing good. She's resting at home. Because what we found psychologically, that when you give a person with dementia or Alzheimer's bad news, they forget about it because their short-term memory is affected. But then, so each time, if I were to tell her that my mother passed away, that her son passed away, what we would have found is that she would experience that grief over and over and over, even though she would forget it shortly after, but that would be a continual thing. And that's why it's important that when we're dealing with the psychological and emotional effects of this disease, that we make sure, as Dr. Blair said, that we follow routines. We make sure that we're doing things that's going to kind of stimulate their brain and keep them busy. And that's more in the preventative stage of it, exercise, doing brain teaser types, things like that. That can be very helpful. Making sure that they're socializing, and even in the midst of the disease, it's important that they socialize, even though they may not necessarily remember what is going on. It's very important that they're able to socialize. And so, as you can see, with all of the information that was shared today, it's not just the person that is experiencing the Alzheimer's, but it's also the family members that are living it vicariously. I can remember in my mother's final days, if she had a good day, I had a good day. If she was, upset, I was upset. So a lot of times family members will mimic the same emotional and psychological effects that their loved one will experience. So I know Andrea has a lot of information on resources and how to care for the caregiver, because if you don't care for the caregiver, then that person cannot care for their loved ones. So it is imperative that we look at and understand the importance of caring for the caregiver so that they can ensure that their loved one have the best quality of life throughout the particular stages of this disease. Andrea?
Thank you, Dr. Douglas. First to science from Dr. Blair, and now Dr. Douglas has shared with us the impact of the emotional and psychological effects that it has on family from a very practical, very organic posture. Thank you, Dr. Douglas, for that information that was timely and appropriate as a follow-up. Andrea, your turn.
Thank you, Dr. Douglas. Thank you, Dr. Blair. Thank you, Dr. Royster, for bringing that. The information was just amazing, and I appreciate that. I think a lot of times we don't look at things from a clinical or medical aspect, and we need to be educated about this disease and disease processes. Today, I'm coming to you from more of an experience of being a caregiver. That's sort of my assignment today, but also to give resources and sort of an understanding of walking through the process of being a caregiver when disease comes into your family and into your life. The role of a caregiver can manifest in so many different ways. I was recently moved by one of my colleagues that I work with, Miss Yelling. She's a registered nurse. And she shared the role of a caregiver as a mantle. And we think sometimes of a mantle as that what's on your shelf, but it's covering. And she defined it as something that covers like a blanket, and that you're covering a person, you're covering something. And I really never looked at my role personally, as I give my testimony shortly, about being a covering for my mother. But indeed, I was put in that role as her eldest daughter and only daughter. But I wanted to share with you a little bit about transitioning into that role, becoming, moving from daughter, eldest daughter, to caregiver, and the importance of putting together a village, creating a team, and a means of support within your circle and beyond, and being able to trust people to do the right thing on your parents' behalf, which happened to be my mother. My mother battled off and on, went into remission 2 times with osteosarcoma. The last time it came back in her spine. And so we knew at that point that it could possibly be terminal, but we also were given sort of what was ahead of us, meaning that she would lose the ability to walk, be wheelchair bound, how it would metastasize because it was in her spine, and certainly toward the end metastasize into her brain. And so there was a lot of memory loss, a lot of agitation, and those types of things. And when you see your parent who raised you, who loved you, we were very close, we were very bonded, sort of go through this process. This was, we allowed her to, be who she needed to be, but also we knew we needed to protect her. I think about what I had to put in place very quickly because our lives changed dramatically. But I had 3 F's, the F's: family, making sure that I had support from my family, and they were very much engaged. They became, my mother's name is Bobby. They became Bobby's Angels, and we used to laugh about that. Friends, finding friends that had resources that were able to intervene for me when I didn't know what to do or how to do it, and being open to accepting help. Because I was a medical licensed social worker at the time, I felt like I could do it all, but I quickly realized that I couldn't. And so I had to learn how to trust others that came into our home, my mother's nurses that we ended up hiring, and then creating an environment for my mom of familiar, and what I call familiar. And so in her environment, things that were normal for her, she wanted to do outings, finding resources to transport her when she became wheelchair bound, so that she could get out into the community and go to church for a little while early on. But things that made and gave her comfort as the disease process. And I think that's very important. Allowing her to have fun and travel. We were actually able to do that. And she went to a lot of the places that she wanted to go. And so I think that those things were important for us. The most important thing for me was the next thing that I wanted to sort of talk about from my perspective is self-care. As a social worker, I knew what that meant. I have preached it. I have taught it at university, the importance of taking care of yourself and providing a space where you as a caregiver can have some respite and downtime of your own in integrating things. And so when my mother became full care, it was really important for me to be able to step away from that and be human and have time for prayer and meditation, have time with my friends, have time to be a parent. I was a single parent of a teenager who was very bonded to my mother, and having him and supporting him through this process because he was losing his Nana, you know. Having exercise, all the things that I did was able to travel when nurses came in and sort of be who I needed to be. Because as Dr. Douglas said, if I wasn't well, my mental health wasn't well, my physical health wasn't well, my mother wasn't well. I think what we don't often realize is the person who we're caring for feeds off of our energy. They feed off of our spirit. As Dr. Douglas said, and Dr. Blair alluded to as well, when you are not well, when you are not happy and your spirit is not intact, they can feel that. When she had a good day, when I had a good day, I wanted her to have a good day. When she had a bad day, I wanted to be that strength for her. And I think it's so important that we wrap people around us as well in the caregiver, and that you're reaching out and providing yourself with respite care. And so later on, I'll give some resources for that as well. And you can find that on a national level and even in your community. But what we were able to do, and God blessed us, my mother was a psalmstress. My mother was a praise and worship leader. I can give so many definitions, but she was the epitome of church. She lived her life. She lived holiness. And what I can tell you is what was important to her was that people around her also were believers and also understood when her praise and worship music came on or she needed to pray, they needed to understand that. And what I can tell you is God blessed us in so many ways. We ended up doing hospice early on, and that's important too. I do want to note that when you become eligible for hospice, it's not just about the last days. There are disease processes where you can integrate hospice early on. And because of my mother's disease, much like Alzheimer's, much like dementia, you can actually access those hospice providers early on when they meet criteria. talk to your doctors, talk to the medical providers that are caring medically for your loved one. We were able to do that. And so hospice came in. They were able to lift some of the burden from me. And we ended up with one of my mother's CNAs who was in the church, and she went to a PAW church. I had no idea. She came in the door, heard the gospel music, and was like, "Oh, what church did you all go to?" And when you saw the look on my mother's face, the comfort, when they would be in there doing her hygiene care, it was magical to hear them singing songs of worship. That gave my mother comfort and familiarity. And it's important to surround them with that. I was blessed to have nurses that were also saved in the church, that my night nurse, when I had to work at night, my daytime nurse toward the end. And it was just a phenomenal experience. But you have to be able to do that. You have to be able to build your village.
Andrea, I have a question for you. What do you think about laughter? I know with my mom, some of the things that she would do, even in the midst of her illness, because she had pancreatic cancer, which we believe metastasized to the brain. So as with your mother, there was a lot of decline. But I can remember there were things that my mother would do that would cause us to laugh, and then she would begin to laugh. I know she used to, she would like to sing as your mother, and she was singing Pass Me Not, O Gentle Savior, and we taped it. And then we played it back for her. And she was like, "Who is that lady singing? She cannot sing." And I said, "That was you." She's like, no, that's not me. I can sing. So laughter really not only helps the individual, but it helps the caregiver. And so sometimes I look at, I'll listen to the tape, and it'll help me to be able to see that she wasn't really gone. She was still there. A part of her was still there. So I think that, as you stated, that being able to laugh, the Bible even talks about how laughter does the soul good, So I think that that's an important part that people will have to, understand that it's okay to laugh.
Absolutely. I can tell you as not a nurse, but a social worker, that there were many of times where I was providing care for her. And my mother would be like, "You don't know what you're doing." I said, "Right, but we're doing this together." And she would bellow out laughing, and we're going to make it, I think, what people don't understand is that I signed on for a journey, and it was a very beautiful spiritual journey. And even outside of myself, I had to experience that. And I looked at it as a journey. And that's what you have to do, in that you're going alongside your mother, your loved one. And we laughed, we cried, we sang songs. There were many of days where it was really rough. And my mother would crack a joke or say something. And she was very funny. She was humorous too. And we would both laugh. And I do agree with that. Laughter is definitely, what they say, the best medicine. Because there were hard times when my mother was young. For me, she was 76 when she passed. And so I referenced that by saying her sisters are well into their 90s and 80s. So I expected to have, my oldest aunt is 95, I believe, or 94. I expected to have a very long life with my mother, and I didn't. And so those times were precious. But I wanted to also talk about resources, because I think it's important that you collaborate with your medical team and your hospice providers. And there are wonderful, wonderful resources out there that you see sort of ticking on the bottom of your screen. And we also included Dr. Karen's as well. But in particular, there's the Karen for the caregivers.com and the Celestine Foundation. Out of my mother's passing, and out of my aunt, who I lost 6 months after that. So my mother's sister also had a debilitating disease, and 6 months later she died. And I was able to share insight with my cousin as they were going through the journey behind us. And out of that birth, the Celestine Foundation, my aunt's name. But we both felt like it was so important to be able to, how do we give back? How do we tell people of color and then, nationally how do we share this? And how do we share these experiences and make them real for people? And when we had trouble struggling to get resources and get, names to what we were dealing with, and sort of, resources that could help our community, they were like far and few between. And so out of that birthed the Celestine Foundation. It's my aunt's middle name. And we were able to collaborate and make jewels of love, and we do philanthropy, and there's so many things. But when you go onto these websites, in particular, the 3 that are flashing across your screen, take a picture and get what you need. We provide caregiver support. Dr. Karen provides caregiver support, knowledge, education, but also resources on how to get those things for your loved one. And so I just think it's super, super important that you access these organizations. The Alzheimer's organization is a national organization, an association. Get the help that you need, educate yourself, and take care of yourself. And that's what I can bring to this, just personally, and what I wanted to provide today, to let you all know, as caregivers, as people of God and people of Christ, and even outside of that, that you are not alone. There are people out there that can give you resources. There are agencies that can help you. There are, people in your church that you may not even know about, and outside of that, that can provide you support. And you can walk through the journey of loss, whether it's Alzheimer's, whether it's Lewy body dementia, whether it's cancer. You can walk through that journey with your loved one with dignity, and that they can die and transition with dignity and happiness. That's all I had.
Thank you, Andrea. You guys are awesome. I think we have spent our time well this morning, now getting into the afternoon. I so much appreciate all of you and what you have shared. I do have a question, and we're going to I know we're perhaps running over time, but I want to allow time for some Q&A. And I think some questions are going to be posted. But Dr. Blair, I have a huge question for you, because you talked about the gene APOE4 and its presence or not in any one individual. Can, say, my son who is in his early 50s and he's doing his annual physical, can he ask his doctor with whatever blood panel that they test for the presence or not of this gene, so that he can be informed and be at least able to be careful about his lifestyle choices, because they are critical, particularly when you have the gene. But can he have that tested and know at that age, or even earlier for that matter? Is that possible?
So thank you, Dr. Hairston, for that question. You would expect to be referred to genetic testing and counseling for something like that. You would talk to your primary care physician provider and be referred for genetic testing to have that done. Yes, you can have testing to find out if you're a carrier. I'd like to add something that Dr. Royster spoke about earlier. Please know that medicine of the future is going to be based on targeted therapy. What do I mean? Right now, we're working on population-based therapy. What is it in the African American community that's predisposing us to being twice as likely to develop this disease? We're looking at population-based therapy. In the future, it's going to be precision-based medicine. My doctor's going to know that maybe I've got a certain gene, and now for whatever reason, that gene has been turned on, and he or she will say, I knew you were coming. Here's the medication that we've created for you. Wow. But we can't do that unless we are lending ourselves to the research, to the genomic testing, and finding out what is it in our genes. Is it our nutrition? Is it our cardiovascular status? What is triggering the gene to express itself?
May I chime in here? I'm glad Dr. Blair brought that up, and maybe you can elaborate just a little bit more without getting into the weeds. Is that how here in the United States, when it comes to Blacks, we are just disproportionately affected by this disease, but yet there are places in Africa where it's almost nil. The numbers are so low. Can you share some thoughts on that, Dr. Blair, for a moment?
Thank you for asking about that. Again, I'm sorry that we're seeing these numbers, but I get inspired because to me, I'm seeing something, right? I'm more interested in those social determinants of health. I'm interested in what's turning these genes on.
Yes.
Is it stress?
Yes.
Is it the nutrition?
Mm-hmm.
What is making them turn on? So that's why it's important to continue with the research and looking into our cells and what's turning those bits of information in the nucleus on to do certain things.
Does deep sleep impact the cleansing of the amyloid from the brain?
Well, sleep is a restorative process. It's important to get sleep because we need to rejuvenate ourselves, right? And so if you're not sleeping well, you are exposed to chemicals such as cortisol that don't help us. And it can lead to chronic stress and inflammation, which you want to mitigate. So sleep is helpful not only to Alzheimer's, but again, to your cells in general. At the cellular level, sleep is a healthy thing.
What about a diagnosis, diabetes diagnosis, in impacting the diagnosis of Alzheimer's disease and dementia?
Yes. So having issues with containing sugars in your blood, these are inflammatory processes that can lead to damage, cellular damage again. So when you're talking about inflammation, this is what is harming our cells and hindering the process of that movement of those lipoproteins that we talked about, those proteins moving through the cell. If you've got an inflammation, which diabetes leads to, it's not helping those cells function optimally. So any comorbid disease that you have, here's the other thing. You're going to find that in the future, the doctor is going to want to know what you may be predisposed to genetically, but it's going to be about prevention. Prevention. We're going to have to control things if they happen, such as diabetes, but it's about preventing the diabetes if we can. And then if we can't prevent diabetes, you have diabetes, controlling it so that you can maintain proper cellular function.
Good. Can CRISPR help to eliminate this in my DNA? If you understand the acronym CRISPR, CRISPR.
Right.
Okay.
So I have not done a deep dive on CRISPR. There is some promise there. Looking at the DNA, looking at how to manipulate the genes there, that is the science of the future. That is the medicine of the future. I just read an article yesterday. There's a young kid that they were giving him genomic therapy to deal with his sickle cell anemia.
Yeah.
This is what it's going to be about in the future. How do we keep those cells from expressing negative outcomes? And how do we manipulate the cell so that it never does express poor outcomes? So anything to do, again, I don't know much about CRISPR, but we're talking about cellular, molecular studies and investigation, and that's where medicine is going.
Mm-hmm. Absolutely.
Dr. Blair, can you talk a little bit more in depth about how the elevation of blood sugar, meaning in diabetes, has to do with the buildup, the amyloid plaques in the brain, and why that would cause people to have a higher risk of developing the disease?
So I'll take one little component of that. We do know that diabetes has a negative effect on your cardiovascular system, for example, right? Well, if your cardiovascular system is compromised, that is going to adversely affect your circulatory system, your ability for your body to generate cells. It's all connected. So if you're not managing your sugars and you end up with cardiovascular disease and your vessels are stiff, you're not producing those cells, those healthy cells, you are putting yourself in a position where these amyloid plaques may then build up, these tau tangles that are building up in the cell. They're destroying the structure of the cell. Now you're losing nerve cells. It's a vicious cycle. So that's why it's important. I like to tell people, I am probably the last nurse that's going to tell you to take a pill. I'm very conservative. I like to start out with talk therapy, complementary alternative ways of dealing with things. However, if you have something that's out of control, it's better to get it under control and then see if you can move on to other types of therapy. It's really important that you get those sugars under control, you get that hypertension under control, you get that cholesterol under control, so that you can do what? Maintain healthy cells.
Thank you.
All
Thank you
right.
for the question.
I see one last question. How can food choices impact Alzheimer's?
Yes. So I'll take, for example, again, those green leafy vegetables and the fruits. You want to make sure that you're consuming foods that will help you with maintaining that cell integrity. Just being overexposed to chemicals. Let's say you're walking down the street and a bus goes by and all that black smoke and all that stuff comes out. So now that carbon monoxide is coming to you and your body is taking it in. Well, your body's probably going to deal with it, but in the process, there is a challenge to your cells. So, and it's called oxidation. And so with having those cells be challenged and there's oxidation taking place, you need antioxidants to help you with the process of recovering from that cell damage. How do you get antioxidants in your nutrition? Your green leafy vegetables, your salads, your fruits, your sweet potatoes. Another thing is you want to limit things such as fried foods. Do you know that one part of our country has like the highest rate of cardiovascular disease? That's the Deep South.
Yeah.
Why? They're thinking that we have a little issue down here with fried foods that we can't seem to let go of.
You think?
And it's hurting. It's hurting our bodies. And if I could have everyone take one thing away today, it would be, if you're hurting your body, you're hurting your cells. So what do I do to make sure that my cells are healthy and make sure that those messages that I want to flow so nicely from cell to cell, what can I do? You can make sure that you're consuming foods that aren't going to contribute to high cholesterol, that aren't going to hurt your blood vessels. If you're eating a lot of, if your sugars aren't maintained, your vessels are going to be taxed. You're not going to have the circulation that you want, the ideal circulation for brain health. Lastly, usually whatever is good for your heart is good for your brain. So take care of your heart, exercise, eat right, control those comorbidities, and you will see that most of that is very helpful and protective for your brain.
Absolutely. And I think Dr. Lillian would say, we are what we eat. Let food be your medicine and your medicine be your food. Amen.
Amen.
I know over Thanksgiving, I got my sweet potatoes in because I made sweet potato pie. And I got my fruit in because I made some apple pie. And so I was careful.
With no sugar, right?
What would it be without sugar? So in the midst of all of the turkey and dressing and greens and all of those things, we did get our fruits and vegetables in on the slide. So thank you all. You guys have been absolutely awesome. Our time has been well spent this morning, getting in now to the afternoon on the East Coast. Just thanking God for all of you and your expertise, your skill set, your knowledge, information. We applaud you today for all that you have said and shared with us. It's been impactful, I know. And because this is a live stream production, I want to thank Evangelist Robin Edmond and the Kingdom Creations Productions for producing this presentation this morning. It will be on our CHEW website, so it can be revisited time and time again on ad infinitum as we go forward. Don't forget now that the second half of the presentation from CHEW will be the topic of ADHD, and other members of the team will follow us after I think a 10-minute break. So stay tuned, all of you that are watching online. Remember that you can contribute if you want to support the Committee on Health, Education, and Wellness. You can certainly submit any gift that you, in any amount that you choose on the various giving platforms that we have available. So go to the CHEW website and you'll see all of that. I would love and appreciate any and all support that you give. We are currently running a Legacy 365 program where we are simply asking for $1 a day for the year. I know we're getting to the end of the year now, 2023, but we'll repeat it going into 2024, that you could support the CHEW Committee on Health, Education, and Wellness with the PAW with $1 a day or $365 for the year. So I would encourage all of my team, CHEW team, to do that before the end of the year, and going into 2024 that we dedicated, set aside dollars for the support of mental health throughout the Pentecostal assemblies of the world. Very critical for all of that. So with that being said, we're going to close out our portion. Again, I appreciate and love all of you to life because of what you have brought to us today that is going to impact us, no question, going forward. So with that as a closing comment or remark, if any of you have something lastly they want to share in like 30 seconds, you can do so. I started with Dr. Royster, Dr. Blair, Dr. Douglas, and Andrea. You're muted, Doc.
All right, there we have it. Once again, thank you, Bishop Harrison, for allowing us to share this platform with you. I commend my colleagues on the panel, just a magnificent job, good information, transparency, and heartfelt. And I trust that our constituents have gained some knowledge and insight regarding the topics that we've discussed. Thank you again.
Well, the Bible says, in all thy getting, get an understanding. And I think that the information that was shared here today is definitely in alignment with the word of God. And I'm sure that it will do the hearts and the minds of the people, not only of the PAW, but also anyone that has access to this. It will do their hearts well as for their loved ones. And thank you for the opportunity.
Excellent. Thank you.
I guess
Yes.
I'll just say that it has been a privilege to be on this panel with all of you. And I hope, again, that individuals will understand the importance of taking care of themselves. Take care of yourselves, and you'll be able to take care of the selves of the others that you love too.
Thank you. Andrea.
Thank you, Bishop. And this was an amazing panel. Even though I'm in the medical field and the mental health field, I'm always learning and growing. And again, I can only emphasize to take care of you so that you can take care of others.
Again, thank you all. I certainly got the feeling that I was in the classroom today because I have been taught, and I think anybody listening will have learned greatly from the presentation today. So may the Lord bless each and every one of you. Evangelist Edmund, you can close us out.
Greetings, everyone, and praise the Lord. Good to see my esteemed colleagues on with me this morning. And we are continuing with our presentation this afternoon. We're going to be talking about ADHD. Okay. So I'm going to provide just a short introduction about ADHD, and we're going to talk a little bit further about treatment and other things. Any questions that might come up, we'll address those as well. So ADHD falls under the category of neurodevelopmental disorders. And these neurodevelopmental disorders create disabilities that primarily are associated with how the brain and neurological system function. And the diagnosis and treatment can be difficult and complex at times. So we want you to tune in, let somebody know that we are talking about ADHD today. Excuse me. So key features of ADHD is that the onset typically occurs early in development. The development deficits produce impairments in functioning, and they frequently co-occur with other neurodevelopmental disorders. They may include symptoms of excess and delays in achieving expected milestones. And there can be differences between individuals with these disorders that need specifiers to help to enrich the clinical description of the clinical course and current symptomology. So when it comes to the prevalence of ADHD, about 9% of school-age children are diagnosed with ADHD and 4.4% of adults in the US. And for children, there's a 2-to-1 ratio, males to female. And in adults, there's a 1.6 to 1 ratio in adults, and females are more likely to present with inattentive features. Okay. So the onset of ADHD may have some comorbidities. Just a little bit more about ADHD. Hyperactivity is the main manifestation in preschool, and most often identified during elementary school years. The symptoms of motoric hyperactivity are less obvious in adolescence and adulthood. A substantial portion of children with ADHD remain relatively impaired into adulthood. There's also internalizing disorders that are commonly comorbid with, meaning happening at the same time in both children and adults. And those include anxiety, depression, persistent depressive disorder, which used to be called dysthymia. Also, they can be comorbid with externalizing disorders, such as oppositional defiant disorder, conduct disorder, substance use disorders, and alcohol abuse. So where does ADHD come from? Adoption studies indicate that heritability estimates are as high as 70 to 80%. That means that if a parent has ADHD, there's a high chance that the child might have ADHD as well. But we need to focus on genes associated with things like dopamine. We heard that in the last presentation. Dopamine is that reward hormone, makes you feel good, that arouses you. A single gene will not ultimately account for ADHD, and MRI and PET scan studies are often done to determine where ADHD comes from. There are also a lot of neurobiological factors to ADHD. The neurobiological factors include differences in brain structure and function, deficits, basic deficits in the frontal lobe activation. That's the front of the brain, where executive functioning is, and we'll talk about that a little bit later. Perinatal and prenatal factors. That means something happening during the pregnancy. Low birth weight, mother's use of substances, environmental toxins, lead poisoning, additives, and artificial food coloring, and nicotine are all neurobiological factors. There are also some psychological factors as well. Parent-child relationship interacts with the neurobiological, and it can lead to negative interactions. Parent history of ADHD, if a parent had ADHD, that affects, for fathers, that affects the parenting style of the father. Fathers diagnosed with ADHD are less effective in parenting, and that can contribute to the development of ADHD as well. So what is ADHD actually? It's a persistent pattern of inattention and or hyperactivity, impulsivity that interferes with functioning or development characterized by inattention, And there are you need to have at least 6 symptoms for at least 6 months to be diagnosed with the attentive type. And the same thing with the hyperactivity impulsive type. And the symptoms of inattention include a child who fails to give close attention to details or makes careless mistakes in schoolwork, at work, or doing other activities, or the individual has difficulty sustaining attention in tasks or play activities, or the person does not seem to listen when spoken to directly, or the person does not follow through on instructions, fails to finish schoolwork, chores, workplace duties, or a person could have difficulty organizing tasks and activities, or inattention could include avoiding or disliking or being reluctant to engage in tasks requiring sustained mental effort, or a person who loses things necessary for tasks and activities. And a person with an attentive type is oftentimes distracted by extraneous stimuli and forgetful in daily activities. Now, hyperactivity and impulsivity symptoms can include a child or a person who fidgets with or taps hands or feet, squirms in their seat, leaves their seat in situations when remaining seated is expected. In other words, they just won't sit down. The person runs about or climbs in situations where it is inappropriate. Unable to play or engage in leisure activities quietly. The person seems to be on the go or acting as if they are driven by a motor, or a person who's talking excessively. These are all symptoms that might fall under the hyperactivity, impulsivity subcategory. Or the person could blurt out answers before questions are being completed. A person has difficulty waiting for their turn, or a person is interrupting or intrudes on others. We've all seen children that fit these characteristics and these criteria, especially the hyperactivity type. Several symptoms need to be present before the age of 12 years old. Several symptoms need to be present in more than one setting. It's got to be behavior that goes across multiple settings. In other words, you see these behaviors not just in at home, but you see them in school as well, or in church, or wherever you might be. The symptoms have to interfere or reduce quality of social, academic, or occupational functioning. And the symptoms do not occur exclusive during course of schizophrenia or another psychotic disorder, or not better explained by another mental disorder. Now, there are subtypes. We just talked about them. A person can be diagnosed with ADHD, predominantly hyperactive, impulsive presentation, or predominantly inattentive presentation, or a combined presentation, which includes the inattentive and the hyperactive impulsive presentation. ADHD can be in partial remission, and they can be labeled in level of severity as either mild, moderate, or severe. Some of the functional consequences of ADHD include reduced school performance and academic attainment. These are things that you'll see the child or the person struggling with. Social rejection, poor occupational performance, attainment, attendance, more likely to develop conduct disorder in adolescence, and antisocial personality disorder as adults. They tend to be accident prone, and for adults, there might be a high probability of unemployment, unable to hold on to a job, elevated interpersonal conflict. They may have a greater risk of substance abuse, and a greater risk of being arrested or incarcerated. The impact of ADHD on individuals may affect their relationships as well, in terms of having discord and negative interactions in families, peer rejection, neglect, teasing. They may be perceived as lazy, irresponsible, or uncooperative. And in their academics, they may have deficits in their achievement, in their school-related problems. They may have school-related problems. And ADHD overall has an effect on our economy. In 2005, it was estimated that $36 to $56 billion was spent annually in America because of ADHD. Now, some of the underlying feelings and emotions that may be included in ADHD include a person with ADHD might feel isolated, misunderstood. They may feel blamed, like they're the scapegoat for everything bad that happens. They may feel like they're not good enough. They may feel stupid. They may have shame and embarrassment. And the list goes on. But also, we're realizing that with ADHD, there are some gifts that come with ADHD as well. People with ADHD tend to be passionate, have an original way of looking at the world. They tend to be intelligent. They may have what we would call an adventurous spirit. They tend to be nonconformists. They have intense focus on their interests. They tend to be creative. They think outside of the box, and they are determined. And so we're going to talk a little bit more. That's kind of the introduction for ADHD. And we want to talk about expecting mothers and what they can do to decrease the likelihood of their unborn child developing ADHD.
Well, good afternoon. It's a pleasure to be here today. Thank you, Dr. Key, for that that overview. It's so interesting, and I'm always so intrigued by this disorder, ADHD. I'm Dr. Lillian Robertson. I'm an obstetrician and gynecologist, and I hail from St. Joseph's Medical Center in Tacoma, Washington. And so I'm often intrigued about this because as an OBGYN doctor, I'm often asked, what causes ADHD? How did my child get ADHD? What can I do as a parent that's pregnant or expecting to conceive to not do to keep my child from getting ADHD? And then when we think about ADHD, it's really, really important to us because many people that are diagnosed with ADHD are highly, highly intellectual. And as you mentioned, Dr. Key, they have lots of positive traits and characteristics that really make them be at somewhat of an advantage. But one of the key things that really stands out is because of their high intellectual ability, they're often underachievers because they just can't concentrate and they can't sustain an interest. And so we see ADHD in social settings, in the classrooms, in the schools. It's often diagnosed as a child, but certainly can extend into adulthood. But it's important to know that it's not a cancer, it's not a disease, it's not anything where the body doesn't function well. It's just that the brain has some challenges and some deficiencies that cause it to not function as well. So first of all, when I talk to ladies that are in the office that are considering conception, I tell them first, don't waste your emotional energy on blaming yourself. If you have had a child that has had ADHD, because ADHD is a neurological disorder in the frontal cortex of the brain, that front part of the brain that is responsible for making decisions, controlling impulses, and good concentration. It's not caused by poor parenting or chaotic home environment or things like that, but a chaotic home environment can contribute to a worsening of this presentation of this disorder. As Dr. Key just explained, it's a chronic disorder of the brain, and that makes it difficult for children to control their behavior. And in the frontal portion of the brain, paying attention gets real difficult because dopamine, the neurotransmitter chemical that is responsible for pleasure, that is responsible for movement, for motivation, for attention, is deficient. And so often due to this deficiency in that portion of the brain, as we will delve into more deeply, children will tend to become hyperactive because it's their way of trying to stimulate this dopamine that isn't there. And as we know, when we talk about children and genetics that is associated with ADHD, we know that a child with ADHD has 1/4 chance of having a parent with ADHD. And 1 out of every 3 fathers who's had ADHD in their childhood will have a child with ADHD. So as we talk to parents about propensity and prevalence, a child with ADHD is more likely to have a relative with ADHD. So we see that there's significant prevalence here. And almost 11% of children in the United States aged 2 to 17 have received the diagnosis of ADHD at some point. And boys are more likely than girls. So if you have a male child, it's more likely to, if he has a diagnosis, to have more hyperactivity. And so I often like to think about this in ways that, and from a biblical perspective, Psalms 139:14 says, I will praise thee, for I'm fearfully and wonderfully made. Marvelous are thy works, and thou my soul knoweth right well. And so we're fearfully and wonderfully made. And so when we think about ADHD, there's that certain component of the brain that the genetic expression will come where the gene that carries ADHD, it's often the epigenetic, that around the gene, above the gene, chemical substances associated with giving the genes information and telling the genes to express ADHD gets impacted as well. And so we'll talk a little bit more about that. And as Dr. Key also mentioned, there's the inattention type, the hyperactivity type. Girls will mostly often experience this inattention type. Boys, again, hyperactive type. So we see, particularly in our African American boys, behaviors that hyperactivity where they may not wait on their turn in line, and they may be disruptive and tapping on the desk all day. And so when we start to notice things like that, we begin to have conversations with the teachers about what's going on with these little boys. But oftentimes when we're talking to our patients in the office, when preconceived and preconception appointments, we're talking about what we need to do as parents to prevent this disorder in our children. First of all, you have to have good prenatal care. Good prenatal care helps to lower the risk for ADHD because we're evaluating things early on. And then we also know that with good prenatal care, your risk of premature births and low birth rate is much less likely. A lot of studies are showing now that premature birth and low birth rate heightens the risk of the expression of ADHD. Also, lead exposure. We want to limit exposure to industrial chemicals and toxins and things like that that may be where you're working in places or living in communities where your social determinants of health suggest that those communities may not have the healthiest in terms of, climates and smoke and, smog, what's in the atmosphere. So we think now and know that that can impact how this gene gets expressed or whether or not the gene of ADHD gets expressed. Maintaining a healthy diet, as we discussed extensively in the first segment, really does matter as it relates to, the prevention and minimizing your risk of ADHD. Excessive preservatives, additives in foods. These are the things we want to limit because we know as mothers, whatever we put in our bodies, we're making a person. And so when we put things in our body, it can impact our offsprings and how their genes are impacted by what we consume. And we want to make sure also that if you're a woman above the age of 35, that you're adding folic acid to your prenatal vitamins, because folic acid is a direct component that helps with neurological development and impacts neurological development. And we know now that ADHD is a neurological disorder. And so it can have some safety and lessen your risk of developing ADHD if we're adding folic acid to our diet. So, and also too, there's a lot of studies that are showing that pregnant women that maintain healthy weight do better and lessen their risk of children having ADHD. So there are studies out that show that. And also they're maintaining a healthy weight helps to maintain good blood pressure control and blood sugar control. Blood pressure control during pregnancy extends the life of the pregnancy. So when we look at, low birth weight and premature births as risk for ADHD, whatever you can do as a pregnant mom to extend and to go to term with your pregnancy lessens your risk of ADHD development. Also, maintaining healthy lipid levels. When you're pregnant, you want to make sure you're eating properly, proper fats, good cholesterol levels, because we see in some studies that does impact how the brain develops. And so we want to make sure we're adding and putting everything in our body because we're building a person that's going to give our child the best possible opportunity to be healthy. Good physical activity is so important for positive pregnancy outcomes overall. And so when you have good physical activity, your circulation is good, your circulation to the baby is good, the growth of the baby is good. All the cylinders are firing at the right rates and right levels. So it just improves your pregnancy outcomes overall. If you smoke, stop smoking. And if you're drinking alcohol, you may want to refrain during the time of preconception, during pregnancy, and thereafter, particularly during breastfeeding, if you're smoking and alcohol consumption. So that may not apply to this group. For others that may, you want to make sure you're watching that in order to give yourself the best possible opportunity to minimize these risks in your children. Birth trauma. There's some things that can happen in terms of in utero, when, fetal distress and things like that can happen during the time. If there is some stress, fetal distress during delivery, it can impact somewhat your risk of ADHD. Because remember, the gene for ADHD is part of your DNA. Whether or not that gene gets expressed is a determination that is determined by epigenetics. So genetics play a role in inheritance of ADHD, but it's the epigenetics that has a role in telling those genes whether or not they're going to express the ADHD symptoms, turn the symptoms on and off for ADHD. And so when it comes to ADHD, there might be a genetic tendency for ADHD to run in families, but it's the environment, it's the nutrition, it's the stress, it's what you get exposed to in terms of toxic chemicals, preservatives, traumatic experiences, and all of the social determinants of health. That influences whether or not ADHD will show up as a trait in your child. So it's not just about the gene that gets inherited. It's also about how your surroundings shape how that gene gets expressed in your child. So prenatal counseling, prenatal visits, talking to your obstetrician and provider, making sure that you're healthy, that you're eating right, that you're going to all of your visits, that you're maintaining good blood pressure, good blood sugar, so that the pregnancy can go the length of the term, 40 weeks plus. And that gives you your best opportunity to lower your risk of having a child with ADHD. Thank you, Dr. Key. Also, when we talk about concerns expressed for mothers of children with ADHD, I get a lot of questions when these mothers come into the office, and now they've realized that their child may have some symptoms of ADHD. They've talked to the caregivers, they've talked to the teacher at school, and so they want to know what we need to do and what can I do once I notice what's going on with my child. And so some concerns that get expressed by the mothers of the child, because the children, as we said, may have attention deficit. They can't pay attention in class. They're hyperactive. They are pushing in line. These kids sometimes will be tapping on the desk or have some impulsive behaviors, because these difficulties need to be addressed very early on, because kids can sometimes get labeled as learning disabled. And as I said earlier, oftentimes these children are very highly intellectual. They're very smart children, but because they can't control these impulses in the frontal lobe of their brain where dopamine is deficient, that's where we get the problem. And these children have noticeable behaviors that can be disruptive in the classroom. So as we said earlier, if your child has signs and symptoms of ADHD for greater than 6 months, you want to discuss this with your pediatrician, discuss this with your teacher, the child's teacher, and discuss this with caregivers, the symptoms that they may have noticed. The babysitters may notice that these kids just don't want to take a nap. They don't want to sit down, or they're throwing food. And so they're disruptive behaviors. And when we notice those, once you become alert of your child's behavior that's different from their peers, talk to the teacher about those behaviors. Ask for a conference with the school counselor. Ask to have a conference to set up further diagnostic processes, and then learn everything you can about ADHD. Take positive steps to decrease the impact of this disorder. Intervention early is so very important, and it's so key to positive outcome in the children, because the earlier you address your child's hyperactivity or inattention, the more likely you'll be able to prevent school failure, because these children are bright. These children are smart, but when they can't pay attention, they can't complete an assignment, they can't turn in their homework, that's when they fail in school. And also, the earlier you intervene as a parent, more likely you are to prevent underachievement. More likely you are to prevent social anxiety and prevent depression that we'll discuss further in a little bit more detail. But the issue that surrounds this failure to intervene, you prevent, if you intervene early, you prevent your child's risk of having poor self-esteem, poor sense of self-worth, delinquency and truancy, not wanting to go to school, not wanting to socialize. So it's important to pay attention. Don't take it personal. Don't get into the blame game, but just know that if my child is behaving this that way, and I'm told this, then I need to look at this more specifically. And when I go to talk to my child's teacher, when I talk to the child's pediatrician, here are some quick questions you may want to just arm yourself with. Ask the pediatrician, what's involved with finding out if my child has ADHD? How will you know? How can I know if that's my child having a problem, or if my teacher just not liking my child? Or if the teacher just not wanting the child's teacher is racist, or if my child is being bullied, or if my child is acting out because, they just don't understand the assignment. So how can I know my child has ADHD? And then you want to ask, what are the treatments for ADHD? And how will the treatments affect my child? And how will I know if the treatment is working? Other questions that may be good to ask is, what are the side effects? If treatment is recommended in terms of medication, what are the side effects of the medication? What types of therapy may be helpful? Does exercise, sleep make a difference in ADHD? And then what is it that I can do as a parent to help my child succeed in school? It's going to be so important to support your child. It's going to be so important for you to engage and to show up and to ask questions so that your child know that there's nothing wrong with me. We just need to fix these deficiencies. We need to tweak some things in our brain so that we can stay on track and function in the way that our peers function. And then other questions you can ask your pediatrician: how long does the child need to be on medication? May not need to be on medications long, because sometimes children can grow out of these symptoms and can function well as an adult. And so I want to just encourage all of our parents, as you're starting to prepare, have children and may have children that have been diagnosed, learn everything you can. Develop a good relationship with your teachers. Keep using the internet to find out things, and make sure you push the fact that your child will get a comprehensive assessment. In some of our schools, that they may not have a child psychologist. Some of these schools may not have funds. So what we talked about earlier is sometimes, you could take your child to the doctor or to a university that may be located nearby and get the help that your child needs for this disorder. Advocate for your child. That's the most important thing. And the other thing you want to make sure of is you want to make sure that the pediatrician tells you the difference of who's being bullied, or if your child is just not getting enough sleep at night. And then also what's going to make a difference in terms of how they will be able to cope with this disorder once they're put back in the classroom. Okay. Nutrition is important. We want to make sure we're eating a lot of protein, that your kids are not overly consuming sugar, because we know sugar causes hyperactivity. And then we want to make sure that we're paying attention to what foods may make our kids a little bit more hyperactive at times than others. If it's things that they're eating, if it's preservatives in food, if it's a lot of fast food. Make sure your child exercises and plays, because that helps with the hyperactivity. That lowers, it raises the dopamine, gives a reward, and it lowers the anxiety rate. And you want to limit screen time. You want to make sure that we are minimizing the stress. And according to the research, making sure that you stay engaged with your child therapist, with your teacher, and really actively be involved with helping your kid get the help that they need. Thank you.
Awesome. Some great information there. Hopefully you're taking notes. But we're going to continue to talk about assessment. Dr. Robinson mentioned assessment several times. You need to make sure that you're having an accurate, good assessment. And the way that the assessment takes place oftentimes are through rating scales. We'll have parents and teachers fill out rating scales that check off like a checklist of the symptoms, the things that they've observed, the things that they see. And the psychologist will compare and contrast to see if those behaviors are happening in the school and at home, because remember, the criteria is that the same behaviors need to be happening across multiple contexts. That's how we'll know it's ADHD. There are also assessments that can assess whether or not the child has difficulty inhibiting behavior. That has to do with the frontal lobe, that executive functioning. Can they control their impulses? Can they stop themselves from jumping in and taking a turn that's not theirs? Those types of assessments, and then just observation, from the parent and from the teachers and all those contexts that they might be in. Even in the church context, you might see that, that information, that input helps a lot, and it helps to get down to an accurate diagnosis. And once you get that diagnosis, then you have to think about treatment. And so we're going to talk a little bit. We're going to have, let's see, whoever wants to go first, whoever wants to talk about medicine for children or therapy for the children. Dr. Wright?
Yes. Hopefully everyone can hear me. Thank you, Dr. Key, for that excellent introduction. Thank you also to Dr. Robertson for that excellent presentation on considerations in parents of children that have ADHD. I'm just going to speak very concisely, or as concisely as possible, about what I will say specifically is or can be an aspect of treatment. I'll say that again. It can be an aspect of treatment, and that is medication. It is important for me to say it that way is because I don't want people to have the misconception that medication is the only way to treat ADHD. But again, it can be a part of treatment and can work along very well with these other things, some of which have already been mentioned, including nutrition, exercise. And I believe Michelle will come along after me and talk about therapy and the role of therapy as a part of treatment as well. So I just wanted to start off with that. What I will say in terms of treatment options for ADHD as it pertains to medications, there are really two very broad or two general categories of medications that are used. And some of you may have come across this in your reading. Essentially, they are stimulants and non-stimulants. Those are the two very broad categories of medications, and there are subcategories underneath those. The point is not to get into a lot of specifics about the names of different medications, but just to kind of go over some pros and cons when these medications are being considered. Generally speaking, as far as stimulant medications are concerned, I will for now just throw out just one name, Ritalin, that being one that came out probably in the 1950s, I believe. So most, if not everyone that is familiar at all with ADHD has at least come across the name of that particular medication. The active molecule there being methylphenidate. Again, that is one of the stimulant medications that can be used to treat ADHD. But speaking about more specifics of stimulants and non-stimulants, the thing to keep in mind with stimulants, a few things. One, there are more options available. There are more medication options available that fall under the stimulant category compared to non-stimulants. And also, as alluded to earlier, the stimulant medications, generally speaking, tend to be more widely used. I'll get into a little bit about why that is. Also, if a parent is considering having their child or children put on medication, as Dr. Robertson mentioned, they should be aware of potential side effects that can be caused by these medications. And I think that goes for both stimulants and non-stimulants. Also, to talk more generally, at the point that someone is considering putting their child on medication, as is said many times in the field of medicine, whether it's a medication or a different type of treatment, it's important for people to understand risks versus benefits. And that's really what it boils down to, risks versus benefits. And these are things that the parent must take into account. And one thing I try to tell my patients about is their risks and benefits of both the treatment and not accepting the treatment. And in some way, Dr. Robertson covered that. And I'll mention also something that Dr. Key brought up as well. But what I mean by that is, a lot of times people get, they kind of get worked up about potential side effects of stimulant medications if they're considering that as a treatment option. But I tell them there are risks to not treating with medication. Dr. Robertson hit the nail on the head. Children may lag behind in school if they're not being optimally treated. Again, that is not to exclude therapy and other forms of treatment. But again, if medication is deemed to be helpful, there are risks to suboptimally treating ADHD. Kids falling behind in school later in life. We get into what that means as far as their job opportunities, career, and things of that nature. So that's something else that I wanted to bring up. And so, looking at a little more specifics again about stimulant versus non-stimulant medication, and there are multiple things that I think parents need to consider when talking about these medications. First of all, some parents would say before they would even consider medication treatment at all, there has to be some assessment of the severity of the symptoms. Are the symptoms severe enough for them to even take the risk of putting their child on any type of medication? And there are many ways there are to assess the severity of it. In a practical sense, I'll just use this as an example. Some parents get to the point where they're getting letters sent home about their child's behavior every day or every week. And eventually that starts to wear the parent down. But not only you have to think about how the child is functioning in school. If the teachers are having to work just that hard to control the behavior, to get the child to sit down long enough to be able to learn what they're supposed to be learning. So just to use that as an example of the need for some assessment of the severity of the symptoms. So that's something to take into account, not only in school, but also as Dr. Key mentioned. Again, this is across different settings. What's the severity of the symptoms in the home? Can the parent get the child to be cooperative enough to do their homework? And that goes for not only the hyperactive and impulsive symptoms, but also the inattention. Many times, and I'll just make this point, many times young girls go a long time without being diagnosed because they're not disruptive in class, but they just can't pay attention. But when the parents start to see a decline in their grades or wondering why, hey, I believe you're capable of making A's and B's, but you're making C's and D's, what's going on there? So, it's important to consider the inattentive part of that as well. Another consideration to make is the timeline that people are working with. And what I mean there is how much time between the time that medication is implemented, if that choice is made, to the time that they want to be able to see results. The reason this is important is because there is a difference. I mean, I have to be honest, between stimulants and non-stimulant medications. Just to use an example, If the decision to start medication is made early in the school year, there's some time there. And looking at the time difference with stimulant medications, most of the time there can be a difference noticed on day one. That is one of the few medications in psychiatry where people can see the results that they're looking for as early as day one of treatment. And so that's something to keep in mind. However, with non-stimulant medications, it sometimes may take in the range of 4 to 6 weeks between the time the medication is implemented to the time that a difference is noticed. By the time they can say, well, I think it's starting to work. So there must be consideration on the part of the parent. Do they have 4 to 6 weeks, to see the difference? Sometimes if people are coming late in the semester or late in the school year, I'll use this example. I had one parent came to me, after we had discussed medication as an option almost 8 to 9 months earlier, going into the previous school year. She wanted to wait on it. I told her that it's certainly your choice to make. And long story short, the child's grades went from A's and B's to straight D's. He was making straight D's. And at that point, I said, well, the best we could do at this point in the school year, maybe we can keep the child's grades from going from D's to F's. So I had to let her know we're not dealing with a whole lot of time here. So it's unlikely that your child will get back to A's and B's this late in the school year, in the semester. But I did let her know that if we started with a stimulant medication, we would have a shorter period of time before we would be able to know if the medication was even working. So that's one thing to take into account. Again, the timeline that you're working with and things of that nature. Also, to touch on this, the potential for side effects. Those are things that need to be considered. Dr. Robertson brought that up. I don't tell anyone that any medication I prescribe for them will not give them any side effects. Now, we see in reality that may be the case, but I tell people that that any medication, one of the best things I learned in residency training, one of my supervisors used to say, any medication can cause any side effect known to man. And that's something that has stuck with me. So I tell people, yes, there are the potential for side effects with this medication. Looking at stimulants versus non-stimulants, in reality, the stimulant medications carry a heavier side effect burden. I don't try to hide that from people. There are the potential for more serious side effects with stimulants compared to non-stimulants. Just to name a few, one of the big ones, particularly if you're dealing with children, is the potential for decreased appetite and weight loss. Decreased appetite and weight loss to the point where some adults, I don't need to spend too long on that. There was a time earlier in my practice where we were trying to weed out adults coming in saying they couldn't focus and concentrate just so they could get Adderall to help them lose weight. But it is important to understand that the stimulant medications can cause appetite suppression. So that's something to keep in mind. And it's important, as Dr. Robertson mentioned, to monitor the nutritional status of your children, whether they're on medication or not. So that's one thing to keep in mind. Sleep patterns. Dr. Robertson mentioned that as well. Stimulant medications can affect sleep in an adverse way. Some stimulant medications for some patients may make it harder for them to relax and fall asleep at night. But it doesn't mean that option should be taken off the table altogether. Sometimes it's a matter of dosing and the timing of when the child takes the medication. There's some medications, if they're given at the quote right time in the morning as a single dose, as long as it gets them through the school day and the homework period, there may not be as much of an effect, if at all, on sleep patterns. That's something to keep in mind as well. The last potential side effect I mentioned, dealing with stimulant medications, is potential to affect cardiovascular status. Now, we know in most normal cases in children and adolescents, they're not coming in with a lot of premorbid cardiovascular conditions. It's unusual that you're going to find a child that already has high blood pressure, problems with their heart and things of that nature. But it is important to take into account family history in terms of potentially prescribing stimulant medications. Probably the biggest or the main question to ask: is there a family history of people in that child's family who have had sudden cardiac death? Did anyone in your family die suddenly, related to heart disease or things of that nature? So it's important to kind of tease that out because you don't want the stimulant medication to potentially affect a condition that the child may not even be aware that he or she has. So realistically, there can be an impact on cardiovascular status. Most of the time in children, they may experience that with symptoms or side effects such as increased heart rate, palpitations, but not necessarily to a point where it's causing their blood pressure to be raised or, bringing on hypertension and things of that nature. One last thing I will say is the consideration for, and this piggybacks off of something that Dr. Robertson mentioned as well, in terms of how long the child will need to stay on medication. There can be variation in that, but certainly when it comes to stimulant medications, I talk to parents about the option for what we call drug holidays. Again, if the goal is to optimize school functioning and what's going on in the home, particularly during the school week, I talk to parents, if their child is on a stimulant medication, about the option of withholding medication on the weekends. Withholding medications on the weekends. And some parents say, yes, this medication is working fine. They're doing well. They're doing better in school, but their appetite is not quite what it needs to be. They withhold the medication on the weekends and the child eats everything in the house. Now, not necessarily that is good, but again, that does help to create some balance, in cases where there may be some concerns about decreased appetite during the week. And the last thing I'll say is that there is also one thing I may do in practice. A drug holiday may include the summer. If the child is not necessarily heavily engaged in academics during the summer, some parents will not only withhold medication on the weekends during the school year, but may give a child a break from the medication during the summer. So that's a good 2.5, 3 months where they're not on the medication. Again, if they're not having to deal with certain side effects, parents tend to like that. But that also gives them the opportunity to observe the child's behavior and make some decision of whether or not they want to resume the medication or start it once they get into the next school year. So that's just kind of a quick rundown of things that I think are important for parents to know and to consider if they are considering placing their child on medication, again, as a potential treatment or part of the treatment for ADHD. I'll turn it back over to you, Dr. T.
Awesome. I actually have a question. So what do you do if you have concern about the addicting quality of the stimulants, and do the drug holidays help with that?
Good question. There, to my knowledge, there doesn't seem to be, and this actually brings up a point that you made earlier. There doesn't seem to be a huge correlation between legitimate use of stimulant medications in children, and the development of substance use issue later on. And I'm so glad you asked that question, because I had written this down while you were talking earlier.
Mhm.
The thing that I try to get parents to see is that it seems to be more likely that the child may develop a substance use disorder later on if their ADHD is undertreated or suboptimally treated in their childhood and adolescent years. And that gets into particularly in males, where there's more of a propensity towards impulsivity, things of that nature. Hey man, try this. Yeah, I'll try it. I'll take anything. And so that's something to keep in mind. And the other thing that I'll mention, hopefully in answering this question, is in most cases we find that if a child truly has ADHD and they take a stimulant medication, they're not really getting the euphoria from it. It's not necessarily that it affects them where they feel high or this sense of pleasure that tends to be associated with someone developing an addiction
Mm-hmm.
to a substance. Whereas some people, they look at it as, hey, if I take this Adderall, it's gonna, speed me up and, make me feel, a high or euphoria. Most of the time, excuse me,
Mm-hmm.
most of the time we're not seeing that as an issue. Again, when these types of medications are given, to a child or adolescent that actually has attention deficit disorder.
Thank you. That really helps. All right. I think I see another question in the chat. It says, what percentage of children grow out of ADHD and function more normal as their peers as adults?
The numbers may have changed since I last looked at this and, went to some lectures on it. But I think it stands at about two-thirds of children and adolescents who experience those symptoms in their younger years. About two-thirds of them will grow out of the symptoms at some point, and there's not really a magic age there. I've seen some as young as about 16 or 17 that, basically, had the symptoms for roughly about, 3 to 5 years. They hit about 16 or 17, and the parents were like, hey, what happened? The child totally changed. So it's not really a magic age, but generally speaking, about two-thirds of children will grow out of the symptoms, meaning that one-third will continue to have symptoms into their adult years. However, those symptoms will manifest.
Great. Thank you. All right. So we've talked about medication, and medication oftentimes is included and combined with other forms of treatment. And we're going to talk a little bit about that, hearing from Michelle.
Thank you, Dr. Key, and thank you all so much. I'm so honored to be on this panel with Pentecostal Assemblies of the World. And one of the things that I appreciated about each of you, because you were talking about things that I believe people can take home. And one thing I noticed Dr. Key was talking about the pros and cons of ADHD. And most people are not thinking about any pros, And then Dr. Robertson talking about the prenatal care that's so important. So not even, before the child's even born, the mother herself taking care of herself is good. And then of course, Dr. Wright. And now one thing about Dr. Wright, I can understand a lot about what you were talking about, because I work with children and I do actually play therapy with children. So I believe that's what qualifies me to be on this wonderful panel, working with many children that have ADHD and also adults. And we're going to talk about that the rest of our time here today. But I definitely talk to children about both options. Of course, play therapy is no medication. There's a different type of treatment helping that child. But some of them are taking medication, and some of them have actually come to me because the medication isn't working. So then we start trying to find other ways to get that child healthy. So I'm excited to be here today. So I want to talk about some of the treatments that we can do, some of the treatments that I do as a play therapist, but really want to give it back to the parent, because that's where the child is with 90% of their time in their life, where the parent can actually engage in some of these things. So I want to leave some tools with the constituents today. But play therapy is a form of allowing that child to explore who they are and their identity and their motor skills connected with play. One of the things I appreciate that as we were talking, sometimes with ADHD, and I really like what Dr. Key said, that, or actually it was Dr. Wright, talking about how 2/3 of our population actually grow out of ADHD. And I think that a lot of this is, some of it is just development. You know, a lot of our children between the age of 3 and 6 years old, especially our boys, they have a lot of testosterone level, and they need environments to play. They need environments to just get dirty and just be outside and run. And when they're cooped up and all that energy is cooped up, they end up doing it in bad behavior because they just don't know where to put that energy. And so it's so important, especially between the ages of 3 and 6, for our boys and all of our children to have an environment where they can just explore themselves in a active environment, because this actually helps them to develop. And sometimes the parent will think there's something wrong with their child because they're so hyperactive and moving around so much, when some of it I can say that it's clinical, but I believe a lot of it is just developmental, you know, just growing and just learning and just trying to understand who they are. And there's even a stage in the child's life where they are withdrawn. They actually are just thinking more, not talking as much, daydreaming more. And the parents thinking, is my child depressed? Is what's wrong with them? And they're just in a very normal stage of their life where they're being more observant than talkative. So one of the normal symptoms you'll see in a child that struggles with ADHD, they struggle in following the rules, and that's definitely hard in the teaching environment. They struggle with finishing what they started. So you give them schoolwork, and they it's unfinished, doesn't look like they even were able to understand what was there. They start playing, and then that play spins out of control. And we're going to talk about that, how play therapy can help with that. So they tend to feel like they're out of control, and then they start feeling like, well, what's wrong with me? Why does no one want to play with me? And then it starts going into their insecurities, and then anywhere from feeling bullied to feeling like they're being, feeling set apart from others. And so it's so important to realize that these are struggles that a lot of our children are facing. And the solution can be very, very easy. It doesn't always have to be going the clinical route, finding them a play therapist or finding them a psychologist. The solutions can be very easy. And I want to share some of that. But first, I want to talk about what I do. When I'm working with children, we're in an environment with toys. There's toys that kind of reflect the real life with the child. For example, kitchen set or things where there are cars, things, of course, there are dolls and things where children can play. There's also an inflatable punching bag for frustration. So we have a lot of different things in that room for that child, and they are specific. They're not just toys we just bought willy-nilly. They're very specific toys, but you can buy them anywhere from your local Walmart or anywhere. But they come in this room, and in this room, they have the environment where they are free to play with anything they want. But what they're learning are limitations. So I give them the environment to play, and they're actually kind of like the leaders. That's what makes them love coming and enjoy coming back, because they're the leader of that environment. I'm following them. If they want to play with the sand, I'll sit and play the sand with them. If they want to play with the Play-Doh, I'll follow them with the Play-Doh. And in that, they're realizing, oh, I can do this, and I can do this function, and I can play with someone. So it increases their social skills, it increases their confidence level, it also increases their understanding of limitations, because they can't run out the room. They're realizing that because they're playing with someone, they have to follow the rules. They have to follow, the conduct of the room, and they also learn a lot about themselves because they're hearing their voice. Children talk so much. I can't tell you how many times when I'll have parents come into the room. Because I'll have like a family session with that child, and they've never heard their child talk so much, or they've never seen their child active so much, because that child is having an environment where they can grow, where they can have an environment to explore. So it's just been a great experience being able to give children that experience to grow and learn. And my children with ADHD, a lot of times, for example, one case I'm thinking of right now, he just would take every toy in the room and put it all on the table, and then he'll play each one. And then, but each one he just give about maybe 2 seconds per toy. So instead of him playing with the toy in its original space, he'll actually take that toy and then bring all the toys into the center of the room, and then play with each of them, but all a couple of seconds each. So I can definitely see where he had a short attention span, and he was already getting bored after just a few seconds of playing with a game. But what happened with that over time, this was just beginning in our session, but what happened over time, he couldn't find a specific toy he was looking for. And then secondly, what started to happen is he was tripping over the toys that he brought out into the center of the room. I think one time he tripped and fell out of the chair. And over the course of sessions, he started to realize that he overwhelmed himself taking all the toys out of the boxes and putting them in the center of the room. And so after, I don't know how many sessions, maybe 5 sessions, he realized, I don't want to move all the toys. I'm going to play with them at their place. And I would say maybe after about 10 sessions of play therapy, he was able to sit down and we were able to play a full game together. He did not need to pull out all the toys. We were able to sit down. He knew what he wanted to play. He knew what he wanted to do. And that showed so much progress because it showed that he was able to, by 10 sessions of play therapy, he was able to sit down, focus, have full enjoyment. He wasn't bored, and he was able to stimulate himself with just one thing instead of moving from toy to toy to toy to toy, which are some of the very typical symptoms of ADHD. So play therapy has shown to be a great treatment. Now, you heard me share about having the parents in the room. Another form of helping a child when you're wanting your child to get healthier in that environment, please find a therapist that is willing to get the parents involved, to have some family sessions, have the child and the parent play in the room so you can kind of formulate and assess how they play together, because that really helps the entire environment. A lot of children, they're in these environments that causes them to be very clingy, very whiny, because maybe the parent is busy. It's very much about the home culture that they're growing up in that causes that, and the attention from the parent is so important. I heard someone share, ADHD stands for attention deficit hyperactivity disorder, but the first part where it says attention deficit, and I heard someone share it from a different perspective, the attention deficit from the parent. So the importance of the parent giving that child adequate attention to where that child feels heard, feels seen, feels played with, and then that will all translate in the way they communicate in school, the way they do their paperwork, their schoolwork, their homework. It'll also communicate in the way they socialize. So definitely find a therapist and find an environment where you as a parent can be involved in your child's therapy and involved in their health. I think it's so important also to where we're also thinking of all categories. Now, play therapy is not the only intervention for ADHD. That's what I was trained in. But there are a lot of different therapies like cognitive behavioral therapy, emotion-focused therapy. All of those can help a child to really be more focused, be able to process that. Neurofeedback therapy is one that I've definitely seen. Neurofeedback is where they're assessing the activity in the brain. And so if a child sees something that stimulates them or or triggers them rather, and triggers impulsive behaviors, the child starts to want to just react. They want to throw something, or they say something that they shouldn't say, or start to cry out of control. And that neurofeedback actually shows where that trigger is, and then that therapist will encourage the child or the adult what to do to help de-escalate themselves. So that therapy is this is a person. This is actually a colleague of mine, so I'm very familiar with that type of form of therapy. But it is also another way of non-medication ways of intervening with a child that has ADHD. So now I want to share a little bit of thoughts about what you can do as a parent in helping your children in their attention span. And now this doesn't always have to be just with ADHD. This can be any child. Because I work with children that struggle with any emotional struggles or aggression, struggling with things that have caused them to be depressed, cause them anxiety. So any of those categories can be helped with this. But let me share this with ADHD. One of the things that you can do in play therapy, a parent can do narrative play with your child. You can like playing house or playing school. I work with a lot of children just the other day wanting to play school. And narrative play is allowing that child to be a role that they see in the everyday real life world. And so they're able to play that role, play the mom, play somebody that is at work, play a construction worker, play a firefighter, and they can play that role, and then you play that narrative out. And that allows the child to kind of process things that they couldn't process before. When you really pay attention to the narrative that they're wanting to play in, you'll start probably seeing a role played out that's in their everyday life. I saw that not too long ago also in my case where a child wanted something at the store, and mother told me the story. He wanted something at the store. They cried, they were upset, and they putting the toy item in the mom's basket because they were determined to have that toy, and then they ended up crying and getting upset because they couldn't have it. Well, I learned about that story, but I worked with the child just regular, and before I knew it, that child was playing that very scenario out before me, and I just happened to know that scenario, and they were playing it out. They were wanting things off the shelf and wanting to buy the things, and they were upset if they couldn't get something. But I started to work with them and started to say, well, are you able to, can you afford all of these things? Because I'm going to get all these things, but I don't know if I can afford it all. And the child started to realize that, oh, okay, there are times when you can get these things with what you have, with the money that you have, but then there are times when you probably can't get it all at that time. So we'll save up another time and get the rest of it later. Well, that helped that child to understand that really to have patience with themselves and really to be able to wait. You won't be able to get everything you see in the store, but you can get this, and then maybe wait till next time, maybe we can get it another time. Or sometimes to learn this is what we have, and enjoy the toys that you have right now. And that's a big lesson for a child, to understand the importance of contentment, the importance of understanding that my mom or dad still loves me even though I don't have this. So playing out narratives are huge, and you can do this with role play. You can do this with dolls. You can do this with animal figures. They can play with the animal figure, and you can ask them, which animal are you? So playing all these out are huge, and allowing them to lead during that playtime. Now, remember, in this playtime, you're still keeping limits, so you're not just letting them do things that are harmful to themselves or to you, but there's gentle redirection that allows them to understand I'm being heard, I'm being seen, and I have this safe environment to play. I hear someone giving a question. Is that just being spoiled? I don't see that as being spoiled. I think they're children that need that attention. They truly need that love. I don't think too much love or too much attention is being spoiled. I think our children really are struggling with lack of it because of our busy culture, our busy environments. The need for both parents working in the household now. So I really think that the need for the child to have that specific time is very important. Now, in light of the parent's busy schedule, that playtime can just be, I would say, an hour a week. It doesn't have to be every day because you may not have that opportunity every day. I would hope maybe 3 times a day, really. You could say, on Tuesday, at 4 o'clock, right after school, that you and that child will have time to play. And that child knows on Tuesday at 4, they're going to get to play with mom or dad and just have 1 hour of just fun. And they're going to look forward to it. Now, let's say they want to play on Wednesday, and Wednesday is not the allotted time for play. They say, I know you want to play today. Today is Wednesday, not Tuesday. We're going to have to wait until our play day, and then we'll be able to engage. And they'll cry. They'll probably not like that answer, but they have to understand the time. Once you train them to understand the time you have allotted for that child, you'll be training them. You'll teach them the limits and teach them such important boundaries that they'll need in their adulthood on how, there are many people that kind of take advantage of each other's time, but being able to understand this is time for this and this is time for that. And you teach them also when it comes to schoolwork, this time for schoolwork, not playtime yet. We're going to do schoolwork and then it's time for play. So it teaches them a lot of healthy boundaries. Thank you for that question. The other thing you can do, of course, is playing outside with your children. I heard of an example of a parent that goes outside with their child in the morning. Now, sometimes the mornings are dark and it's cold, but this particular parent will take their child outside. They'll play in the grass. They'll play in the sand. They'll play in the snow if it's snowing. And then after 30 minutes of that, they'll come inside, get ready for school, and go to school. And that parent has found that it's helped the children to not be as whiny, as clingy, and then they're ready to get ready for school. They have a great day in school. They're not disrupting the classroom as much, and just having a good day of correlation, self-regulation and correlation. And so that could be helpful. If it's not possible to do it before school, you can do it after school, but you give that child a time to just connect with you and get to know you. One of the things that's also different about society is that, you've ever heard that saying, it takes a village to raise a child. So it was more than just the mom and the dad raising that child. It was aunt and uncle and neighbor next door that saw the child doing something and brought it to the parents' attention. And there were pros and cons to that, but I see more pros as far as the child realizing that they had an environment that cared about them and that was watching them and that wanted to see them do well. And so it helped that child to really understand that, I'm accountable to all my family and all the people that are around me. And so I want to do my best. And so it can be very helpful to allow the child to explore environments. That's one of the healthy things about children that go to church, because in church there's a community. They have other children that they go to Sunday school with and they get to play with, as well as school, and other environments that they get to explore and be able to play. The other ways that you can play with them, so far we talked about narrative play and playing outside. The other way you can help and connect with your children is through puppets. Now, puppets are fun because you're able to also do narrative play by playing out a scenario with the child. It actually reminds me of Mr. Rogers. I don't know if anyone remembers Mr. Rogers, and he did a lot of puppet play. And through that puppet, he'd act out emotions. He'll say, "I'm sad," and I had a hard day today because someone was trying to hurt me. Look at me, I'm doing my fingers here. You can see I'm a play therapist, and so and that puppet will express, "I'm sad, I'm hurt, and somebody tried to hurt me today." And then you say, "Oh, well, who tried to hurt you?" so and so tried to hurt me, and then you're talking to that child, and the child will talk to the puppet more than they'll talk to you as the adult. So sometimes I'll talk to that child through the puppet and communicate with them. The parent, you as a parent can do that as well. You'll find out that they'll feel more comfortable expressing their anger and sadness that way. And it could be a silly voice, it doesn't have to be something that's hyper serious. It could be a very fun environment and give that child an experience. We have a question. Let me read it right away. It says, during play therapy, how are you able to distinguish between managing anger management and ADHD? Yeah, so there's definitely a difference there. However, some of the similarities are lack of self-control. So anger management, anger issues, let me put it that way, and ADHD are both lacking self-control. And so in a playroom environment, it gives them those limitations and helping them to identify where they struggle with self-control. But there is a difference. I would notice, for example, anger children would express with more hitting the inflatable punching bag or throwing things, and that'll be definitely something I work through mostly in the first 3 or 4 sessions. After that, a lot of that subsides. But ADHD tends to go on just for a little bit longer because that's more so how they're just pulling out a lot of different toys. They're doing one thing a couple of seconds per thing. So it's more so of their attention span to focus on one thing. But then you have other extremes. I believe Dr. Key shared about this, how there are some symptoms of ADHD where you are very hyper focused on one thing, and you can get a lot done. And there's a lot of people that are extremely successful with ADHD because they are so hyper focused and they can get things done and achieve very, very great things. But then there's another level of ADHD where you do struggle with focusing on one thing, and then that affects your work development, that affects your performance at any kind of job. And so it's so important to really teach that child how to be healthy in focusing and doing one thing at a time. And that comes with patience. And I'm hoping that some of these tools work as a parent. You can work with your children, helping them process that. The last way of connecting with the child, for example, is if the child, for example, you couldn't go to the zoo. Let's say you and that child wanted to go to the zoo, but it ended up raining or end up being too hot, something happened and you couldn't go. So you can stay home and fantasize the zoo, have like a play time with that child and imagine where the giraffes will be, imagine where the elephants would be. They can either draw that out for you or you can play that out in your living room or in their room. And it gives them that time. So even though they couldn't go, they still feel like they were there because you're playing fantasy with them. So it's a huge, great way to connect with your child and help them through ADHD. Okay, so that was just my thoughts that I wanted to share when it comes to play therapy and what parents can do helping children with ADHD and really any behavioral concerns that you may have with your child. But I want to just finish off my part with things that you can do with your children, just when it comes to emotional coaching in general, because sometimes our ADHD children can be very emotional. They're crying easily, they're easily stimulated. And so I want to share some things. And a lot of these are very biblical. The renewing of the mind, where the Bible says in Romans chapter 12, verse 2, where it talks about the importance of the renewing of the mind. And that's with all of us. It's important to remember that the renewing of the mind is continuous. And so when you're working with someone that has ADHD, it's important that they do their own spiritual work when it comes to the word, when it comes to praying, but also when it comes to teaching themselves. I have one where I actually read books on ADHD, and there's books out there which are really, really good for children. That's children related, age appropriate, where you can educate your child on what ADHD is so the child doesn't feel so different. Why all the other children finished their schoolwork, but I didn't. And it helps that child to be able to understand who they are and what their limitations are, but also how to overcome those limitations. So definitely find age appropriate books for your child to educate them. But I'm going to share just 6 things you can do to help your children in emotional coaching. One of the things is to model those emotions. So establish effective communication. Teach your child to express his or her opinions and needs in a respectful manner by modeling the behavior you want. Speak to your child in a kind but firm tone. And that is definitely in the Bible, where it talks about the importance of modeling, being Jesus like. Want people to be like you're actually modeling Jesus, and you want people to be like you, who's being like Jesus. And it's the same thing for your children. A lot of times when a child is overwhelmed and they're getting angry, that parent also starts getting frustrated, frustrated and overwhelmed, and they start to mirror that child is seeing the parent get upset, and then the parent's getting upset, and 2 parents being upset does not resolve the issue. It actually just escalates the 2. And so be sure to model that behavior. It's very hard for that parent, because the parent's frustrated. They want the issue to just be fixed, but the child is no longer hearing the instructions. They're only hearing that their parent is mad. And so it's so important to model that. Be like a thermostat. I share this a lot with parents. There's a difference between being a thermometer and a thermostat. So a thermometer just reacts to the temperature. So if you put the thermometer in the mouth, or a thermometer that's in your home, whatever the temperature is in your body or in the home, it responds to that. But a thermostat, you set it to the temperature you want it to be, and that home will respond to that temperature. And so you as a parent want to be a thermostat in your home. You model that behavior you want to see in your home, so your child can mirror that and say, okay, you know what, mom is going to be this way, and I need to follow suit to the thermostat that she's put, the setting that she put for me. Have clear rules. Now, those that have ADHD tend to remember, their minds are struggling to focus. So be sure that your rules are clear. So have clear rules. Be clear with your child, what you're expecting from them, what you want to see from them. A lot of times, some rules can be negotiated, but a lot of times they're non-negotiables. I understand. This is what it is, but you make sure it's very clear to your child. Number 3, keep your instructions brief. Keep your instructions brief. Don't let it be too complicated. Let it be very easy for that child to remember. When they go to school, they'll remember this is what mom or dad said, and that'll help them to be able to remember that information. Number 4, be consistent. This is a hard thing with our children. They struggle with understanding what's expected from them, and they're not consistent with it. Parents say, I'm going to do this, and then don't follow through. And so number 4, be consistent with your rules. Be consistent with what you expect. Be consistent with modeling what you would like to see from your child, being a thermostat in that home. It's very important, especially, at school, they have rules. They know they're going to be here at this time, be here at this period, and it helps the child to remember where they're going. So consistency, children thrive on consistency. All of us thrive on consistency, but it's very important when a child is struggling with ADHD to have that. Follow through. Number 5, the importance of following through. If you say you're going to do it, follow through. If there are consequences to their behavior, follow through. This is so important. A lot of parents forget to follow through, or don't want to because they feel bad. So it's so important in teaching the parents to follow through with what they said they're going to do. And it kind of coincides with being consistent. And then lastly, have patience, which is very much a fruit of the Spirit. Have patience as a parent. You're going to feel like you're saying the same thing over and over and over, and that is what you're doing. You're repeating yourself, and God has to do that a lot with us, repeating himself. And so remember to Be okay with repeating yourself. But set those limits. You can say, hey, I've said it 3 times. Now this is the consequence. But be okay with repeating yourself, because patience would be important. You're keeping those boundaries, and mind you, when you're being patient, there's still boundaries there. I'm not definitely not saying to allow your children to push those boundaries, but definitely be patient with them. Continue to be consistent with them. Repeat yourself. But in light of that, after a while, practice will make perfect with that child, and they'll start to understand, mom loves me. This is what she's expecting from me, and I want to make her happy. And as that child gets older, it'll really help them in the long run when it comes to keeping a job, relating to their boss, and things like that. Okay. Thank you. Back to you, Dr. Gee. Oh, I think you're muted.
Sorry about that. Awesome information. I appreciate that. I was writing some things down myself. Good information. I think what stood out to me the most was the importance of parents being involved in the treatment of children with ADHD, how involved they need to be. So thinking about therapy for children with ADHD, I'm just thinking about the training that parents need to go through themselves, to be able to model behavior and to be on your P's and Q's like that all the time, because the ADHD individual will speak up on the fact that you are not consistent. I have a 20-something-year-old individual that I work with who actually has ADHD, and he just can't keep a job. He hates every job that he has. His room is a mess. He doesn't really maintain relationships for a long time, and he gets discouraged. All of the things that you mentioned are that happens to individuals with ADHD, he experiences. So nobody wants to hang out with him. He doesn't have a lot of friends. Mom is always upset with him because she's a teacher, and she doesn't understand why he doesn't get it, and he beats himself up and has low self-esteem and all of those things. But some of what you all shared today really is going to help me to help him. He's on medication, but he doesn't like the way the medication makes him feel. He's in his early 20s and he feels like he's losing mass. In your 20s and you're a young man, you want to be bulk, you want to be muscular. And he notices that he doesn't want to eat sometimes, and he feels like he's getting smaller, and that's a big thing for him. He really focuses on his outward appearance as as an advantage for him. So, this is important information, because we come across individuals like this in our churches. Sunday school teachers need to know this information. Youth ministers need to know this information. It's only going to help, and, God forbid they're an adult, and they're dealing with this, there's a whole nother set of training that you need to deal with the adult as well. So.
And Dr. Key, I just want to even add, what I just listed was, of course, tips that I give to parents, but these are tips that, like you just shared, you can give to churches. The importance of being patient, the importance of consistency, all of those are highly important when it comes to adult relationships. And I just want to throw this in there. I read somewhere where someone was alluding that possibly Peter in the Bible had ADHD because his impulsive behavior. Anytime God talked to him, it had to be 3 times. God really was worked with him, but however, God loved him because God doesn't look at he looks at the heart, right? And God looks at the person and he works with them. I believe that's why the Lord taught us with parables, because he wanted us to understand in clear form how to be better individuals and understand the kingdom principles. So I really appreciate you sharing that. He'll be fine. If he follows those principles, he'll be fine.
So there's another question right here that says, should the discipline process be any different in ADHD children?
It depends on the child. I'm thinking there's some children, for example, one I could think of, spanking is not always the way for this child because of how emotional this child is. This child actually has a more of a violent flare about them with their ADHD, and so that whatever that violence that they experience at home starts to reflect has started to reflect at school. So that's always the right way to go. But then there are some other children where you're communicating with them and you're talking to them. There's just different ways of disciplining children, and it's not necessarily different with ADHD. I think the only difference specifically with ADHD probably would be the repetitiveness. You'll probably have to repeat your instructions often, and don't feel like the child is being rebellious or stubborn or hard-headed. Sometimes they just forgot, and their hard mind but good heart is trying to do the right thing. And so just be okay with repeating yourself, and they'll be fine.
That's really good, really good. You can't beat ADHD out of a child.
Dr. Wright, I have a question for you. What could you just share a little bit the potential for addiction in untreated children long term? And then secondly, what we see a lot is promiscuity in young women that become sexually active early, and they do so because of that dopamine deficiency, and they're seeking that activity. So could you just address a little bit about that as it relates to, pros and cons of medications for those two instances?
Yes, very good question. I touched on it briefly, and I think I may have just mentioned males. But again, there's the impulsivity aspect of it that can be seen in both males and females. But speaking to the potential for addiction or substance use disorders later in life, again, it's, I heard a saying once. A man said, the best way to put out a fire is not to start it. And so, again, if you're dealing with things like substance use disorders or addiction, you can't become addicted to something that you never try. So if you think about children and adolescents who have a tendency, or if they score highly on the hyperactive or impulsivity subscales, they don't necessarily think through consequences of their actions. Their MO is to act first, think later. So there's a tendency for those children and adolescents maybe to be more prone to trying, illicit substances, and we know that is very prevalent. I remember years ago being surprised to learn that national data on substance use disorders went back as far as age 12. And I'm thinking, gosh, what would a 12-year-old be doing? But again, with there being exposure to these things in school, in neighborhoods, in the community, that is something to take into account. So again, if you're not really treating, or if you're not optimally treating the impulsivity, there can be a tendency for the child to, get into, other things, substances. And again, this may not apply to all of our audience. Even things like alcohol, if some parents, I have to tell them, look, if there's alcohol in the home, you need to think about that, making sure that's not accessible, to the child. And also, Dr. Robertson, as you mentioned, as far as sexual promiscuity in young females, certainly we see that as well. Males also, but again, the risk, if you look at it as there being a higher level of risk, or a different level of risk in young females, because they could become pregnant, that is something to consider. Very briefly, I remember hearing about when I was in residency, one of my students who came across a 36-year-old great grandmother. And I was like, wow. But basically, he was working in a clinic, and he was talking to this lady. She had a daughter when she was 12. That daughter had a daughter when she was 12, and that daughter had a daughter when she was 12. So this lady was 36 years old, and she was a great grandmother. Again, I didn't, ask all the specifics or tease out all the history, But I just use that as an example of something that we could see as a result of impulsivity. Hey, not really thinking through consequences. What could happen if I do this. But again, certainly if you see that, or if it's undertreated or not treated at all as an aspect of ADHD in young females, that can lead to pregnancy at an early age and things of that nature. So,
Thank you. You're muted.
Sorry about that. Do ADHD children feel like killing themselves because of the medication? Is that a side effect, or I guess that's what they're asking?
That that could be an issue. Of course, we didn't get a lot into comorbidity, or we may have touched on it. But I like to remind people that it is possible for a child, or an adult for that matter, to have ADHD, but also a comorbid mood disorder as well. The one thing I did not mention, and this is something to really keep in mind, particularly with stimulant medications, is there's a tendency towards mood fluctuations, even if it's not formally diagnosed as bipolar disorder. With children, adolescents on stimulant medications, and some people that may tip the scale too far in the hypomanic or manic direction, as far as mood symptoms are concerned. So again, not necessarily that there's a direct connection with medications used to treat ADHD and suicidality, but it is important to tease out, to evaluate, to see if there's also a coexisting mood disorder as well.
Thank you. One question, in your opinion, Dr. Key and Dr. Wright and Dr. McQueen, do you think that ADHD is untreated widens our pathway to the prison to pipeline system in African American children?
I'll go first briefly. That's a resounding yes for me. Some of it we've touched on already, particularly in young males. With society being the way it is, it's more likely that young Black males may be inaccurately labeled as oppositional defiant, or conduct disorder, which later in life develops into antisocial personality disorder. So yes, I think it is possible that unrecognized or untreated or poorly treated ADHD certainly can lead to these things. Again, I think we have to focus on the fact that there can be behavioral symptoms, behavioral aspects to this condition as well. And so, yeah, that would be my answer.
I absolutely agree. The school systems that we have today, they're looking for that just one behavior, that one opportunity to label, particularly Black males as problem children. And they take them out of the classrooms and put them in the other classrooms. And, it becomes a self-fulfilling prophecy. They feel like, well, I'm bad. I'm in this room and I've got to do what I need to do to get my needs met, and I think it just starts a whole process. So that pipeline, absolutely. I agree.
Yes, and I agree with you both. And I have to say also that I noticed that, and it's actually been admitted to me, that a lot of my clients come to me simply because I'm an African American woman, and so that parent feels more comfortable to come to me, feeling like they want their child to be in a fair environment, recognized environment, understood environment. And so absolutely we live in this sinful world where systemically there is finding divide in any way, shape, or form, specifically in racism. And so systemically, it's affecting our children. And I'm hoping that platforms like this is eradicating that to bring light to that, bringing them the right information they need with to this culture specifically to get them healthier.
Awesome. So we are wrapping up, and if anyone has any last words of encouragement or suggestions around this topic of ADHD, please feel free to share that.
I just like to reiterate the fact that nutrition plays a huge role, obviously, in children and in adults, and making sure that you're boosting your protein intake as children, as adults, limiting your sugar, and then making sure you're getting fruits and grains and just a whole diet full of nutrients that come from the ground and rather than the factory. Less fast foods, less preservatives, making sure exercise is a complete part of the things that you do every day, limiting the screen time, getting good sleep, and really managing the stress and encouraging parents to just stay engaged, stay the course, be a part of this experience, learn everything you need to know about it. And I think supporting your children, really, that's our best way to get the best outcome from this.
Unknown caller.
Thank you, Dr. Robertson. I was actually going to talk about that as far as definitely after what Dr. Wright talked about with medication and then me working through therapeutic interventions. But a huge part is the way the child eats, their everyday lifestyle, the things they watch on TV, their screen time. Those are all vital things to help your child live as healthy as possible in this environment that we live in. And screen is now more and more accessible. You know, see 1, 2, 3-year-olds playing with a screen, and so it's so important for them to move and be outside because that screen time actually inhibits their body to move and have that healthy motor function. So I want to finish off with a poem. It's a very short poem, but it's specifically to parents that are struggling with children that have ADHD or any behavioral concerns. And I just want to share this with our parents. If I had my child to raise over again, I'd finger paint more and point the finger less. I'd do less correcting and more connecting. I'd take my eyes off my watch and watch with my eyes. I would care to know less and know to care more. I'd take more hikes and fly more kites. I'd stop playing serious and seriously play. I'd run through more fields and gaze at more stars. I'd do more hugging and less tugging. I would be firm less often and affirm much more. I'd build self-esteem first and the house later. I'd teach less about the love of power and more about the power of love. It matters not whether my child is big or small. From this day forth, I'll cherish it all.
Wow, that's powerful. Yeah, I think we underestimate just the blessing that these children with ADHD can be and what they can teach us. You know, some of our most successful individuals are individuals who have grown up struggling with ADHD. You know, we have people who have been in the Olympics, you know, people who have become actors and, you know, all types of things. And then we come to find out, oh, they had ADHD. I'm thinking to myself, no wonder they're so creative. You know, I had a colleague actually who became a psychologist, but he had ADHD, and it was so interesting to watch him in class because he would have his computer divided in half with notes on the left side, but a video game playing on the right side. And he wore a yellow watch, and he explained to us that that yellow watch would stimulate him. He would sit his watch on his desk next to his laptop and just look at the watch, you know, and the yellow watch would stimulate him, you know. So, and he was the student in the class that you wanted to be on in a group with whenever we did presentations, because he was so out of the box and so creative with the presentations. Like, you know, you were going to get an A with him. So, you know, we got to learn from these kids. You know, God allowed them to have what they have, and I mean, we shouldn't write them off. We should just, you know, allow God to use them and say, Lord, what can I learn? And that poem speaks to that. Anybody else? Any last thoughts? I think I want to reiterate what Michelle gave us in terms of tips for us. We need to model behavior. We need to have clear rules. We need to keep instructions brief. We need to be consistent with rules, expectations in our environment, and modeling of our behavior. We need to follow through with what we said we're going to do and have patience. Those are all good things dealing with anybody, especially if you're a leader or a parent. You can use these skills and it will make a big difference in, how the child comes out and how your household is, and maybe even in just, in your home period. So keep that in mind. And
thank you, Dr. Key. And I even want to remember our adults that struggle with ADHD. I know I'm talking from the child level, but our adults that need that support, and not to rule themselves out when they're struggling with that, to be able to be patient with themselves, prioritize, and be able to make the right choices, get support, and they'll be okay.
Nice. All righty. So there you have it, ADHD. Hopefully you had enough attention span to watch this and hear us talk. So, we look forward to continue coming to you with great topics and information. God bless. Take care.